You can do the count, Sunil. Mr. Sunil?
Yes, ma'am. We are live.
Oh, okay. A very good evening to one and all of you. We look forward to yet another ARC webinar on neuro-ophthalmology, hoping to bring in more light and more information to clear some of those gray areas in ophthalmology for our dear postgraduates. We are lucky to have with us on the expert panel Dr. Rashmin Gandhi, Dr. Sujata Guha, and Dr. Mahesh Kumar, each of whom have contributed so significantly to the learning of ophthalmology in our country. Dr. Rashmin Gandhi is a born teacher who has a supreme ability to make the most complex learning simple and relevant. He completed his FRCS and underwent his neuro-ophthalmology training at Wilmer Eye Institute and is presently the consultant at CFS Hyderabad and the managing director of Foresight Worldwide. Dr. Sujata Guha is another charming and a very prolific personality, a major strength to the SN Calcutta, a leading pediatric and neuro-ophthalmology surgeon, an academician, and a leader herself. Dr. Mahesh heads the very vibrant neuro-ophthalmology department of the Arvind Eye Care Systems at Madurai, with his major contributions to patient care, academics, and its growth. A true teacher. I would be assisted in moderating this session with Dr. Jyoti Matalia, who heads the neuro-ophthalmology department at Narayan Nethralaya, Bangalore, a renowned neuro-ophthalmology and pediatric surgeon with a great presence nationally and internationally. We shall now go on to our first speaker of this session, Dr. Randhir Jha, a leading name in neuro-ophthalmology from Patna with a very meritorious career and presence. He is going to be talking to us on managing double trouble. On to you, Doctor.
Am I audible?
Yeah. You can share your screen.
Yeah. Oh, okay. At the outset, I am thankful to the ARC whole team, especially the chairman ARC, for giving me this opportunity to speak before this August gathering. Well, I'll be talking about managing double trouble, that is basically managing diplopia. Well, this is a condition wherein an asset of binocularity become a liability for a person. This condition has potentially many causes and many anatomical structures are involved in this. Well, what is diplopia? It is a condition wherein more than one image of the object of regards are seen simultaneously. So it is just an abnormality of the binocular vision. So what are the prerequisites for having a binocular single vision? Very important to know for a postgraduate, like we need to have a perfect or near perfect alignment of the visual axis simultaneously on an object of regard to have a single binocular vision. A perfect or near perfect retinal correspondence, a perfect central fusional capability, a perfect alignment of the retinal receptors, and a perfect optics to allow only one image to be formed on the retina of the same single image to be formed on the other. So these are the prerequisite to have a binocular single vision. So the question arises, when does a diplopia occurs? It occurs when more than one image of an object of regards are formed on a retina of one or both eyes. That is, we can have more than one images formed on only one eye. That condition we call it as a monocular diplopia. And the more commonly which we basically encounter and we are more concerned with is a condition where we can have a binocular diplopia, that is a diplopia occurring only when both eyes are open. So how to differentiate between the two? The only thing we need to do is cover one of the eyes. If it persists even after closing one eye, that means the patient is having a monocular diplopia, because a binocular diplopia will be there only and only when both the eyes are open. So again, for the postgraduate, it's very important to differentiate between a monocular diplopia vis-a-vis a binocular diplopia. Well, there are many causes for the monocular diplopia, like light diffraction, metamorphopsia, or sometimes you can cerebral polyopia can present with a monocular diplopia. So in that condition also we need to carefully look at carefully examine the patient's eye, like some conditions like keratoconus or some Iris anomalies like can present with the double vision. Even any abnormality in the optics of the eye can give you more than one images, and so the patient can perceive a diplopia in one eye. More importantly is the conditions which are basically related with the lens, that is lenticular polyopias. So all these things are will be very much evident on the clinical examination itself. So we are basically more concerned as a neuro-ophthalmologist with the binocular diplopia. Binocular diplopia is due to the misalignment of visual axis. It is a condition wherein an image fall on a non-corresponding parts of both the retina. The image falls on the fovea of the fixating eye and the extrafoveal retina of the non-fixating eye. As you can see in this case, the left eye is fixing and the image is found at the fovea of the left eye, whereas an extrafoveal area of the right eye. You can very well see that the extrafoveal area is basically localizing to the same side, and the patient is perceiving a double image, which is basically it's a non-crossed, because the eye is basically convergent, and so it is giving you a non-crossed diplopia. So there is a mnemonics we used to remember that C is not convergent, is not crossed. So even if you remember one, the other can be just an opposite of it. So this exotropias will present with a cross diplopia. So again, this is a very important question which comes in, which are asked in the examinations, and you need to you need to know it very clearly. So there can be many causes of binocular diplopia, right from the orbital disorders to the neuromuscular restrictions to the neuromuscular junction, or you can have a palsies of various nerves, or even the brainstem injury or a supranuclear injury. All these things will be covered by the subsequent speakers. So the as we all know that the basic defect is a deviation in a case of diplopia. So the deviation can be a concomitant deviation or an incomitant deviation. It is a hallmark of binocular diplopia is a hallmark of an incomitant squint. This every postgraduate should keep in their mind. But even we can have diplopia in a concomitant squint also sometimes. Like, some if you have mostly the concomitant misalignment are seen in congenital early onset strabismus, and they typically do not report diplopia. But when it occurs when in later in life, when a degree of ocular misalignment changes, like if you have a fusion breakdown, you can have binocular diplopia. Like in a long-standing exophoria, which it develops horizontal diplopia when accommodation and the convergence capacity wanes, or even in intermittent divergent squints, also you can have diplopias when the patient is not able to fuse it. Other conditions are the divergence insufficiency, convergence insufficiency. These are basically very common, and sometimes the patient can present with the diplopia. So the diplopia is basically a hallmark of an incomitant deviation. Again, it is frequently acquired and usually causes diplopia. If the deviation is very small, fusional amplitude may eliminate the diplopia. So there are certain incomitant deviations also wherein you cannot have diplopia. So normal fusional divergence, everybody has to remember that it is 8 to 12 prism diopter for near, 4 to 6 for distance, and a fusional convergence is 35 for distance and 18. Whether it has got a range, these values should not be in a single digit. You can see it on a textbooks. So you can have two type of pathology in incomitant deviations. One is a restrictive pathology, another is a palsies. So as the palsies will be covered very much in the next few by speakers. So I'm basically talking about the restrictive pathologies, and the most common type of restrictive pathologies is the thyroid associated ophthalmopathy. So in this, the inferior and medial rectors are mostly involved, and it is associated with proptosis, chemosis, lid retraction, and lid lag. A very important thing to differentiate between a restrictive pathology and a paresis is the force junction testing. And in this case, thyroid associated orbitopathy, you can have a differential IOP in different gauges. And of course, the CT scan will give you a confirmatory picture of the muscle thickening. Again, the blowout fracture can present with the diplopia and the down gauges. Sometimes even the post extractions, post cataract extraction, people present with the with diplopia, but these are mostly the transient type of diplopias. Even post pterygium surgery, when there is injury to the medial rectus, can have a diplopia. Rest of the things are basically not that very common. So how to examine a case of diplopia? The examination of a case of diplopia, or rather of a squint, starts the moment the patient comes into your cabin. So a patient's abnormal head posture can tell you many things about the type of deviation. So in a chin elevation or depression, it can be a vertical squint. A face turn to right or left side can be because of the horizontal strabismus, and a head tilt to right and left shoulder can be because of the torsional diplopia or torsional deviation. So there are, I mean, these abnormalities should be looked for. Very important to look at the pupillary reaction in case of especially the third nerve palsy. So abnormal ocular posture which will be evident on the torchlight examination only. You need to do a prism bar cover test in any case of an strabismus. You have to look at the extraocular muscles, movements, both ductions and the versions. Another thing which you have to look at is the saccade. A floating saccade is suggestive of nerve palsies, whereas a normal saccadic velocity limitation indicates a restrictive muscle. So the to differentiate between a paratic and restrictive etiology, you have a force reduction test, or sometimes you can even use a differential IOP. And a force generation test can tell about what how much strength a paratic muscle has. So basically, what I would have considered most important is the two diplopia. One is a diplopia charting, and another is a Hess or Lee charting. So, what is diplopia charting? This helps in recording the subjective deviation, asking the patient to quantify the separation between the double images, which are dissociated by the red-green goggles. This can be done in all nine position of the gauges at both distance and near. What are the main points to be noted are that it has to be this distance of separation between the two images is to be noted. Position where the maximum separation is present is to be noted, and see the image from which eye is more deviated, crossed and uncrossed, and tilted image. All these things one must ask the patient about diplopia. So what are the prerequisites for a diplopia charting is it has to be done in a dark room, and a slit light source is important. It should be a horizontal slit light for a vertical deviation, and a vertical slit light for the horizontal strabismus. The patient wears the red green goggles. Normally the red on the right eye. This is how diplopia charting will be there in case of a left six nerve palsy. Important here lies basically this diplopia is to be written in the way the patient perceives. So if the patient's if the patient is seeing in the levo version, the diplopias are the maximum, whereas in the dextro version it is having a single binocular vision. So this is how patient will tell you about the diplopia in case of a left six nerve palsy. I mean, if there is a confusion, one can write right and left and can represent it opposite way also. But the most commonly represented way is this, as the patient perceives. Next is the Hess charting. It is a suitable test for the ocular deviation. It is a quantitative measurement of the action of the extraocular muscle. It is based on the principle of haploscopy, which is basically a presence of NRC. Two objects presented to the two eye will superimpose if they stimulate the fovea of the two eye. The prerequisites for a Hess charting is a good vision in both the eyes, central fixation, and a normal retinal correspondence. So a lease charting is basically you have a septum, mirror septum, and one eye fixate and we chart the field of the other eye. And fixating eye determines the innervational input, and the excursion of the other eye is basically charted. So how do we interpret Hess or Lee chart? A compression of the spaces between the two plotted fixation points indicate the underaction of the muscle acting in that direction. Expansion indicates an overaction. Smaller field belongs to the eye with the paratic muscle. Unaffected eye shows larger field expressing the overaction of the contralateral synergist, and fields of the similar shape and size seen in concomitant deviation, whereas the dissimilar shape and size are basically represents an incompetence. These are some of the examples. As you can see, this is a case of a right little lattice palsy. This is a right eye field. You can see that there is a restriction in the dextro version. So how do we interpret these fields? Well, first we have to look as to which eye is affected. The eye which has got a smaller field or restricted field is basically an affected eye, right? Like in this case, it is a right eye field, which is basically smaller. And now we have to look at which, in which direction of the gaze the movement are restricted. You can see this is basically in the dextroversion, which corresponds to the lateral rectus of the right eye, and thus confirming that there is a paresis, there is an underaction of the right lateral rectus muscle, and you can see overaction in the contralateral synergist in the other eye. So this is how we interpret a Hess or Lee chart. These are some of the...
Dr. Jha, can you please conclude? It's more than 10 minutes.
Okay, just 1 or 2 slides. So next we have to do some of the investigations. Very important that most of the palsies basically are vascular in pathology. You have to look at, you have to find out the diabetes or and if you are having some history suggesting some neuromuscular abnormality, you can examine accordingly. About the treatment, I think most of the we have to treat the underlying cause. Unilateral eye occlusion therapy with either an eye patch or can be used. Prisms can be used. Botulinum toxin is a very good option. And of course, if it doesn't get, the diplopia is persisting even after 6 months, we have to resort to surgery. Thank you very much for your kind attention.
Thank you very much, doctor. That was a very thorough talk. I know you needed 15-20 minutes to do great justice, but I think would have been very relevant to the postgraduates and many of us here. Dr. Jyoti, can you take that one question, because I think we are not within time.
Yeah, so I just wanted to ask panelists, Dr. Ashmin can take this, that would you advise diplopia charting and research charting for all patients, irrespective of whether it's competent or incompetent, just that whether the postgraduates will know whether they should do it in their clinic or not?
I think there are two aspects of the question. One is the theory, what postgraduate should reply to in the exam, and one is
right. Yes,
happens. And I think for the exam purpose, I'm sure all examiners would expect them to mention diplopia charting and S charting as a part of a workup and a follow-up.
Right. Right. And Dr. Sujata, you would just want to re-emphasize why it's important to differentiate a monocular from a binocular diplopia. You are muted. Can you unmute yourself?
Sorry. Yeah, for the postgraduates, the first thing to know when you have a patient of diplopia is whether it is uniocular or binocular, because if it is a uniocular, the whole answer goes in a different direction. If it's a monoocular diplopia due to some cataract or some corneal opacity, then you really don't need to do the extraocular motility sense diplopia charting, and all the evaluations will not be required. So the first thing to do is to determine whether it's a monoocular or a binocular. So the entire list of examination will change.
Right, yeah. Thank you.
One tiny question. Then what would be the key features to differentiate a paratic from a non-paratic squint, Dr. Sujata?
Yeah, so number one is primary deviation and secondary deviation. So between a paratic and a
non-paratic.
Non-paratic. Okay. So number one will be a force duction test. Number two will be force duction test is the main test which can differentiate between a paratic and non-paratic, and also like differential intraocular pressure is one of them. This can also differentiate. So these are the two main tests.
Yeah. Just to add, one more point is
Acute yeah.
Yeah.
Yes,
no, just to add that we can look for floating saccades. That's one way to differentiate also in there. I think we can move to our next talk. Now that there has been a ground created for binocular diplopia, let's go and see the actual causes that we get, starting with actually the paralysis, paratic, that is the third, fourth, and the sixth nerve paresis. We have Dr. Swati Fuljale, who will be talking on managing the third nerve palsies. She's the Associate Professor of Ophthalmology at the RP Center, AIMS, specialist in strabismus, neuro-ophthalmology, and glaucoma. She's also the managing editor of the AIOS Times, which you must be getting the EE Times by the Indian Neuro-Ophthalmology Society, and a very good friend. Over to you, Swati.
Am I audible and is my screen?
Yes, we can hear you, Swati.
Yeah,
we can see your slides also.
Yeah, thank you, Jyoti. I would like to thank Team ARC and especially Chairman Dr. Chitra for providing me this opportunity. And I would like to be, I'll try to be as brief as possible. So to begin with, management of third nerve palsy, it's important to first classify third nerve, whether it's a congenital third nerve or an acquired third nerve, whether it's pupil involving third nerve or pupil sparing third nerve, whether it's a complete third nerve or partial third nerve palsy, because most of the time our differentials and our investigations are tailored according to the type of pathology that we see. So coming to the etiology of third nerve palsy in adults, in young adults, it is mainly because of compression. It could be because of aneurysm or any neoplasm, any mass lesion for that matter. In older age group, for example, more than 40 or 50 years of age, it is mainly vascular ischemic, what we call as ischemic nerve palsy. There can be associated risk factors like hypertension, diabetes, or any inflammatory lesions. In children, it is usually congenital, and trauma is one cause which is present all across the ages. Irrespective of the age, trauma is the most common cause for this nerve palsy. So as we all aware of the clinical features of third nerve palsy, it presents as a divergent squint. This is true for the complete third nerve palsy, where there is a complete complete fascicle of third nerve is involved. That there is a divergent squint, the eye is downwards, and only movement that is possible is the lateral movement. The pupil, if pupil is involved, is fixed and dilated, and there is anisocoria. Ptosis is unilateral if it's a fascicular involvement, and third nerve palsy at times could be part of various syndrome. But the clinical features of third nerve depend on the location where it gets involved. So to begin with, we have here the nuclear lesions. So there are many causes of nuclear third nerve palsy, ranging from infarction, infections, inflammation, compression, hemorrhage, and sometimes demyelination as well. So it's important to know the basic anatomy of third nerve nucleus. It's a very intergrowing nucleus in itself. It's not a nucleus, a nuclei which has multiple subnucleus and resides. It's located at the midbrain at the level of superior complex and spreads across the vertical meridian. So as it is visible in this particular diagram, you have the pupil Edinger-Westphal nucleus located dorsally and rostally, while you have unpaired caudate nucleus, which is located caudally. Then you have all other paired nucleus for each of the recti muscle. So if the complete nucleus is involved, you will have bilateral ptosis because there is one single nucleus for both the LPS. You will have pupillary involvement in both the eyes and ipsilateral third nerve palsy. There can be sometimes sparing of LPS if the lesion is involving the rostral area where the pupil involvement would be more prominent, and if the lesion involves the caudal area, then pupil would be spared. So depending on the lesion, depending on the location of the lesion, we may have either pupillary sparing or bilateral sources. But one thing that needs to be remembered when you want to differentiate a nuclear lesion from the infranuclear lesion is ptosis, if present, will always be bilateral. And pupillary involvement, if present, will always be bilateral. So these are the important features that will differentiate the nuclear from infranuclear lesions of third nerve palsy. And another thing that I think is important in third nerve is that the superior rectus is the only muscle that gets, contralateral innervation. So you may have contralateral superior rectus palsy also in these cases. So after the nerve exits through its nucleus, it travels ventrally through midbrain at the level of tegmentum, where it is very closely associated with very important structures like red nucleus, cerebral peduncles, and cerebellar peduncles. And that is the reason why it presents with various types of syndrome. When the lesion is at this level, at the level of tegmentum or at the level of red nucleus, you may not have isolated third nerve palsies. You may have third nerve palsy in association with various syndrome like Weber syndrome, where you have contralateral hemiparesis, Benedict syndrome, where you have extrapyramidal syndrome or extrapyramidal symptoms if the red nucleus is involved, Nath-Nagle syndrome, where you have ipsilateral ataxia because the cerebellar peduncle is involved in this case. So it's important that you can localize the lesion of third nerve if you have this kind of coexisting syndrome. Now, after that, it travels in subarachnoid space where it is related to all kinds of arteries, and that's why it is one of the most common common nerve to get affected by various kinds of aneurysms. Particularly posterior communicating artery aneurysm is the most common type of aneurysm which affects third nerve. Then you have superior cerebral artery aneurysm, posterior cerebral artery aneurysm. Other causes at this region could be ischemia, neoplasm, and of course trauma. So a word about pupillary involvement, and it's important for residents to know that pupillary involvement is seen more in compressive lesions. Why? Because these fibers are located more dorsally and more superficially. So whenever there is a compression, whenever there is an external compression, these are the fibers that will get compressed. While if there is an ischemia, so the vessel is inside the substance of the nerve. So whenever there is ischemia, the substance of the nerve is first to get affected, while the pupillary fibers are relatively spared. So in ischemic lesions, it may not get so frequently involved, but it's not a sacrosanct thing. We have known that even ischemic lesions can have anisocoria. Around 20% of ischemic lesions can present with pupillary involving third nerve palsy. So this particular case is just to show anisocoria with the left third nerve palsy. And sometimes if there is aneurysm, you will have acute neurological dysfunction, meningismus, and early pupillary involvement may be sign of a ruptured aneurysm. Then this is just to show how an ischemic third nerve palsy will present, as in this case, the right third nerve palsy is there. There's a complete third nerve palsy, medial movement and elevation, depression, everything is affected, but the pupil are still spared. So the common causes are the vascular risk factors that may be there in such cases. Then at the cavernous sinus, it enters the cavernous sinus, lateral to the post-clinoid process, where it is in relation to various other cranial nerves. And whenever there is any lesion at this particular area, you may not have an isolated third nerve palsy. There may be other cranial nerve involvement, particularly fourth nerve involvement or fifth nerve involvement. So please don't forget to check for other extraocular movements if you have third nerve palsy in this area. And also please don't forget to check for corneal sensation, which is a very, very important sign, a localizing sign where the lesion could be. The causes could be again thrombosis, neoplasm, inflammation, embolism, microvascular occlusion, or sometimes AV fistulas as well. So at this stage, at the location of cavernous sinus, third nerve is particularly vulnerable to injuries at its entry, and trauma has to be severe enough to cause skull fracture and other problem. If it is not severe enough to cause, if it is minor, what I'm trying to say, if it is a minor trauma, a trivial trauma, then probably you may have to explore the other causes of third nerve in such cases. Not only trauma and not only the ischemia, as I said, compression in this case, in this area is also common, and pituitary adenoma is one of the common cause of compression at the area, at the location of cavernous sinus. Then it enters the superior orbital fissure, where it gets divided into two divisions: the superior division, which supplies to LPS and superior rectus, and the inferior division, which supplies to inferior rectus, inferior oblique, medial rectus, and pupil. Even though it has been seen that this is the most common area for the division of the third nerve, but division can be seen as early as at the location of the subarachnoid space as well. So even that can be possible. So this is just to show a case of a third nerve palsy where the inferior division is involved, and you can see that the elevation is well spared.
1 minute.
Sometimes third nerve palsies can present as isolated muscle palsies like superior rectus, inferior rectus, and particularly medial rectus. So you have to be very careful about isolated medial rectus palsy, for which the most common differential is internuclear ophthalmoplegia. I'm sure it would be spoken about in subsequent talk by Dr. Subramaniam. So I'm not going to get into detail of it. I'm just trying to show few cases where you have the right eye, where you have this orbital fracture and the loss of medial rectus, where you have isolated medial rectus palsy. Then even neurocystic sarcosis can present as isolated medial rectus palsy, or for that matter, any extraocular muscle palsy. And it can present as both paralytic as well as restrictive squint. So you have to be aware of this particular condition. And if you have an isolated involvement, please look into the orbit rather than looking into the brain.
Time's up.
and how to go for evaluation, take a proper history. There can be no substitute for a proper history and proper examination. So ask about trauma, pain, other systemic associations. As I discussed, there are various signs and symptoms of third nerve palsies, and do a complete neurological examination to know the associated neurological syndrome. Then don't forget to look for aberrant regeneration. It is very, very important, particularly the aberrant regeneration of lid in relation with downgaze or adduction, and aberrant regeneration of pupil in relation to adduction. Now, sometimes aberrant regeneration, otherwise aberrant regeneration is most commonly seen with trauma. But if you have a history of trivial trauma or no trauma at all, please explore for the other causes, and imaging may be needed in such cases. So coming to the how you approach this case of third nerve palsy, if you have pupil involved, imaging is the first step that you need to do, irrespective of the age or irrespective of the cause. But if pupil is spared, then again please look for whether it's a complete third nerve palsy. If it's a complete third nerve palsy and there is history of risk factors, you may get away doing follow-up and neuroimaging if no improvement is seen on follow-up. But if there is a partial third nerve palsy, so it may be still be an evolving third nerve palsy, and pupil may get involved at later stages. So be careful. Either you follow them up very, very closely so that you know when pupillary fibers are getting involved, or you do an imaging to know if there is any compressive lesion or not. So role of imaging is essentially to rule out any mass lesion in form of aneurysm, aneurysm or tumor. Indication include, as I said, if the patient is young, pupil is involved, we will have to do neuroimaging, and particularly MRI. Please remember this, that the MRI is investigation of choice for these cases. If the patient is more than 40 years of age with pupil involved, you may still have to go to do neuroimaging. If there is an history of aberrant regeneration with no or history of trauma or very trivial history of trauma, please explore for the other causes. Then this is just to show.
Swati, can you conclude? It's more than 10 minutes.
Yeah, that's my last slide. So just to show how third nerve in our paper, we have shown that 90% of traumatic third nerve palsies have pupillary involvement, but around 36% of ischemic third nerve palsies also had pupillary involvement, and the recovery rate is very, very high in ischemic group, which is a known thing. What I'm trying to say that ischemic group or the inflammatory group can improve, so there is no need to rush into the surgery. You can wait very well for the surgery till at least for 6 months, and these are the options for the surgical treatment of the third nerve palsies. With that, I conclude. Thank you.
Very much, Doctor. That was
Thank you, Dr. Swati.
And I, for one, really enjoyed hearing you, and it was like a revision and getting updated. A question, actually, this question is sort of a repetition of what you've already said, but maybe you could answer it a bit differently if you can. How do you manage a pupil sparing partial third nerve palsy in a 68-year-old diabetic? Would your answer differ if the patient were a 34-year-old?
Definitely, there would be a difference. If it's a 68-year-old and has a risk factor in form of diabetes, I would very closely follow up, because it's still a partial third nerve palsy. So you don't know when the pupil would get involved. So it's better to follow them very closely, maybe 2 weekly or so, and see if the pupil is getting involved or not. If the moment you have pupillary involvement, probably you may have to go to neuroimaging. Vis-a-vis, if you have a 30-year or a 38-year-old without any risk factor, you straight away have to go for neuroimaging.
I think Rashmin had a point to say. You have to unmute, Rashmin.
So the only difference, Swati has covered it, only difference is that when you say partial, do you mean that pupil is not involved, or do you mean that all extraocular muscles are not involved? Because please remember, the rule of pupil applies only to the total third nerve palsy. If it's a partial third nerve palsy where let's say only elevation is deficient or adduction is deficient, then irrespective of whether pupil is involved or not involved, it is prudent to go ahead and do neuroimaging, because as I said, rule of pupil involves to complete third nerve palsy and pupil spared.
Right. Thank you, Dr. Rashmi.
Yeah, Dr. Randhir, you want to say something?
Yeah, ma'am, this is basically apart from postgraduate teaching, but I think neuroimaging should be liberally done in any, this palsies basically nowadays in the era of so much medical legal this thing.
I think Dr. Sujata wants to make a point. You can unmute.
See, for postgraduates, when you're looking for aberrant regeneration, remember when you're looking down, don't lift up the pupils with your finger, lift up the upper lid with your fingers. You might totally miss an aberrant regeneration if you examine like that. Something like if you are doing this to look at the inferior gaze, then you will miss the aberrant regeneration. That is point number 1 for PGs. Point number 2 for postgraduates, the imaging of choice will be MRI with the MRA in a third nerve palsy answer. Okay, so MRA is to look for the aneurysm, which is an important cause of third nerve palsy. These are the 2 points I wanted to make.
When would you do a CT angio?
Or MRA or a CTA. Usually we will, yeah, either of the two. Yeah.
So I mean, I'll go on to our next speaker. Our next speaker is Dr. Digvijay Singh, who has specialized in pediatrics, glaucoma, and neuro-ophthalmology, and is practicing in his own center, the Noble Eye Care, after his stints in different reputed institutes. He has a rich experience of dealing with complex surgeries and has a special interest in diseases of the optic nerve and brain. He is going to be talking to us on managing fourth nerve palsy. On to you, doctor.
Thank you, Dr. Amurthy, and it's a pleasure to be a part of this session. So without further ado, I'll shift to managing trochlear nerve palsies. Is my screen visible to everybody?
Yes, you can go on.
So, we've already discussed the third nerve palsies, and Dr. Randhir has already covered very nicely how to manage situations of cranial nerve palsies, particularly where diplopia is involved. So, trochlear nerve palsy is no different in terms of the presentations of double vision. However, the kind of double vision we get is different. So, I'll come to the finer points, the specific points for trochlear nerve palsy, not to have repetition of what's already been discussed. The first and foremost thing is the trochlear nerve anatomy. So the trochlear nerve, or the fourth cranial nerve as we call it, is the longest cranial nerve, and it's got about 75 millimeters long. It comes, which is coming out dorsally, and it is then crossing over completely towards the other side, and it is at the level of the inferior colliculus, and then it travels down the lateral wall of the cavernous sinus and through the superior orbital fissure into the orbit, and where it is innervating the superior oblique muscle. So all postgraduates must be aware of the neuroanatomy. It's a very important thing, because based on just the neuroanatomy alone, you can predict where the lesion would be if you find certain clinical signs and symptoms. So for a trochlear nerve palsy, the important points in history that you want to look at, of course, the presenting complaints will be double vision or diplopia. You will have a squint which is present. So there is a hypertropia. The eye is generally upwards. So somebody would say that the eye has gone up. You'll have a head tilt, which is a more common thing that people actually notice, or somebody else other than the patient himself notices. And you would have asthenopic symptoms of eye strain and mild palsies, and sometimes neck pain because of a persistent head tilt. Some of the questions that you must have, particularly asked if you're asked in the exam also, is whether the double vision, is it horizontal or vertical, or whether it is also torsional. So specifically ask for this. Ask the patient if they're having difficulty climbing downstairs or having difficulty in reading. Because again, these are cases where the superior oblique works best, and if it is paralytic, then you'll end up with diplopia in those positions. You do, of course, want to ask about, certain other histories as well, such as systemic histories. And, just like other things, diabetes, hypertension, cardiac events are associated with trochlear nerve palsy, though it is a lesser cause. A more common cause is trauma. And in cases of head trauma, even closed head trauma, which may appear mild, trochlear nerve palsies are often noted. Sometimes they would be congenital. And in those cases, you want to look at a family history, because you can get an autosomal dominant pattern. In the examination, the first thing that you must always say is that I will examine the head posture of the patient as he's entering the room, because I want to look for the head tilt specifically. And you also want to look, in case you're getting a congenital superior oblique palsy, in your examination from a distance, you want to look at the maxillary hypoplasia. It's often there on the side of the superior oblique palsy in congenital palsies. But remember, congenital could often be bilateral, and you may miss this. Then in terms of the prism bar cover test, or the cover test alone, you want to look at the hypertropia in the eye, which is the paralytic eye. And you want to look at the 3-step test. And I'll come to Park-Bilchowski's 3-step test in the next slide. That is very, very important. A diplopia charting, as you've already known. You want to do a Hess or a Lees charting, that's there. and you want to look at the torsion specifically. There is a specific need to measure the torsion in cases of superior oblique palsy, and there are ways to do that. There is a subjective torsion and an objective torsion. If you want to look at it subjectively, you can ask the patient, either you can give them a red filter in one eye or a Maddox rod, and then you can ask them to see how the two lights, when you give a point source of light, how the two streaks are differing. And you can look at it objectively as well on the synoptophore. And you can also look at the torsion on the fundus. And I'll show you one fundus picture where you'll be able to see torsion. So you should know how to measure torsion. That's important in cases of superior oblique palsy if you get in the examination, or even otherwise in your practices later on. And you want to do the vertical fusional amplitudes. This is kind of the gold medal question. In cases of bilateral congenital superior oblique palsy, often the vertical fusional amplitudes may be increased or raised than normal. This is what the 3-step test looks like. So first you look at the primary position. Here you can see that there is a left hypertropia in the primary position. Then this is the first step. The second step involves the patient looking dextrogaze or levogaze. In the dextrogaze, you can see the hypertropia is increasing in the left eye. In the levogaze, in fact, the difference in hypertropia is decreasing. And third step is to look at the head tilt. So a tilt in one direction is going to lead to an increase in hypertropia, as you see here. This is in the direction of the parotid muscle, and the tilt in the opposite direction leads to a decrease in hypertropia. Based on the 3-step test, you can actually tell which of the vertical muscles is parotic. Here you would have, typically in a superior oblique palsy, there'll be hypertropia in the palsy eye with palsy. It will increase on the opposite gaze, and it will decrease on the opposite head tilt. So you must know this test, and you must be able to demonstrate this test as well. Diplopia charting has already been covered. The specific thing to remember for trochlear nerve palsy is that you'll get vertical diplopia, and you may also get torsional diplopia, where the patient tells you that, one of these streaks is one of the colored lights that you're showing in the red-green glasses is a little tilted. So no matter how much you try to get him to fuse, because of the torsion, it's sometimes difficult to fuse for that patient. Then you have the Lee or the Hess charting, already been shown in the past. So you have a mirror septum which dissociates two screens, and then you have these fixate pointers, one of which is used as and the eye is a fixating eye. The other eye's excursion is what we are measuring. And here you see on the Hess chart, you'll get torsion, you'll get an inferior oblique overaction. So it's hypertrophy, the eye is gone up, and you'll also sometimes see inferior rectus overaction. So you should again know what to look for on the Hess chart, and sometimes these are given in spotters. For management, and I've already discussed the torsion that you need to measure. In terms of management, if you're asked, you can say that, I'll be doing non-surgical management initially, which could include correction of any systemic risk factors if there are, or you could give some occlusion to prevent the diplopia or the double vision that the patient may be facing. You can teach them certain head tilting or head posturing to remove the diplopia. So if he's tilting the head towards the opposite shoulder, if I got a superior oblique palsy in this side and I tilt my head this way, the double vision will reduce or disappear. And you can give prisms. Again, this is a stopgap measure while we are waiting for it to recover, since most of these palsies may recover on their own, particularly where you're looking at ischemic causes. The surgical management is the definitive management of superior oblique palsies. And this is particularly more so in congenital palsies and palsies where there are trauma or tumors or other lesions, iatrogenic causes, surgery has caused it. And the choice of surgery depends upon the classification or NAPS classification, which is based on which way, where is the maximum deviation in the two eyes. The basic idea is to either weaken muscles such as the inferior oblique, which is an antagonist, or to strengthen the superior oblique itself. Or you can do a surgery for torsion, as we see at the side here, where we are only working on the torsional fibers, which are the anterior fibers of the superior oblique muscle. Some of this goes into the strabismus category, so I'll stick to what from the neuro-ophthalmologic point of view. So I'm just doing a brief cover here. So NAPS classification tells you if the double vision in a right superior oblique palsy is in the up gaze and the left gaze, then we know the inferior oblique is actually overacting. If it is in the down gaze, it's class 2, where the superior oblique alone is underacting. It could be in the entire levo gaze, levo and down gazes, or it could be bilateral. So based on this, you can get this from a book. You'll know the classification, and based on that, the surgery that has to be done. So if it's the inferior oblique, which is basically doing the mischief and making the eye go more hypertropic in its gaze, then you want to weaken the inferior oblique. If it's just the superior oblique, you want to strengthen that. So I'll come to a strengthening procedure of the superior oblique, or you could weaken the inferior rectus or do a mix of different procedures. So you'll easily get a table like this in your books. You should know what surgical procedures can be done. As postgraduates, if you get your principles right, that's fine. You don't necessarily have to know every procedure here. Let's look at a few cases before we close. Here you can see that there is a hypertropia here in the left eye, in the first case, which is increasing maximally in the right dextro elevation gaze and not so much in the dextro depression gaze. So here we want to weaken the inferior oblique. So we do a procedure called the modified Elliott-Mankin, and we get this correction in the post-op period. So again, this is NAPS classification 1, class 1. In this case 2, you can see that there is actually not much hypertropia in the primary position itself. If you see, it was more of a torsional complaint that this patient had. And here we again tackled the inferior oblique, but we did a special procedure called the anterior and nasal transposition, where we shifted the inferior oblique from towards the nasal side so that it would now act like an intorter rather than an extorter. And you can see the fundus here. You could see that this macula should typically be a little below the disc here. It was above, and post-op you can see that the torsion has got corrected. It has come down. This is the normal position of what it should look like. In fact, this is slightly intorted. So you should know that it's on the lower 1/3 part of the disc that the macula lies. Another case here is a congenital third nerve palsy, both eyes involved. You can see that there is no significant hypertropia specifically seen here, but both inferior oblique are overacting, and there is a head tilt on one side, so there is asymmetry, and this is often possible. Here we had to do a bilateral surgery of the inferior obliques, weakening one more than the other. So we chose a recession in one eye and a modified Elliott-Mankin in the other. These are just examples to show you what there is, what can happen. The last two, this is again a congenital third nerve palsy in a patient who was having trouble, and again he was, in his case we saw that the superior oblique was actually weak, a little lax, and the maximum deviation was in the down gaze. So we did a procedure called the superior oblique tuck, and now you can see that the hypertropia has completely disappeared. The last case here is the case of a gentleman. Look at the amount of head tilt. When you see a head tilt of this amount magnitude, you know that it is essentially torsion, which is which he's going to be having trouble with. And you can look here, not much hypertropia, mostly a torsion. And here we did a special procedure called the Harada-Ito, where we are only tenting the anterior fibers of the superior oblique, which are meant for torsion, and we are strengthening them. And look at how the head tilt had corrected substantially. And this was those patients who were presented with severe neck pain as well. So all in all, superior oblique palsy, management-wise, in terms of approach, it is similar to the other palsies. Specific pointers, the points I've told you here. And some of these, if you can specifically ask in your history and your examination, then you're actually bound to do very well if you get a case of superior oblique palsy. Surgical-wise, I've kept it just to give examples in this, focusing more on the neuro-ophthalmic perspective of it. Thank you.
Thank you very much, Dr. Digvijay. Wonderful talk. And the simple question is torsional diplopia common? If so, where?
So superior oblique palsies will often have torsional diplopia. In fact, a lot of times patients may not know they're having a torsion. It's when you make them realize by doing an opposite head tilt that they'll realize, oh, things have changed. And however, small amounts of torsion, 3 degrees or so, they can fuse as well. So, if you don't have to always treat small torsions, it is only the larger amounts that you're not able to fuse. And unfortunately, even prisms don't work on torsion. So, in that sense, but yes, there is torsional diplopia, and there is a patient, whom I kind of made him realize that there's a torsion, and he's been very unhappy after that. He says, I didn't know it before, and ever since you've told me, now everything appears torted. So certain small torsions actually also can cause them to have distress. It's just that, they may not realize it, but it's always there.
I'd just like to welcome Dr. Prem. He's joined us and he's our keynote speaker for today. Had a question for him. Dr. Prem, are you there?
I'm here. Yeah.
Yes, hi. So wanted your opinion about neuroimaging in unilateral or bilateral cases of fourth nerve palsy.
Neuroimaging is relatively low yield in those cases, and I really go from the history. If it is acute onset, if they have very small vertical fusional amplitudes as opposed to large fusional amplitudes, and now if they whip out their phone and show you their photos on Facebook and they've had a head tilt for years, then it's more likely to be a long-standing or congenital fourth nerve palsy, as was mentioned, and the yield of neuroimaging is lower. I'll discuss it with the patient, but often won't do it. But if they don't have a larger fusional amplitude, if it's more recent onset, I can't convince myself it has been there for some time, then I'll do the neuroimaging because it's important in those cases.
Dr. Sujata, any tips on how to differentiate a unilateral from a bilateral fourth nerve palsy?
Yeah, one of them is the torsion. If the torsion is more than 8 degrees, it is most likely that it is a bilateral superior oblique palsy. And also the vertical will reverse. So if it's a right over left in one gaze, it will be a if it's a right hypertropia in one case, it will be the left hypertropia in the opposite. Say it's in the right case, if it's a left hypertropia, it will be a right hypertropia in the opposite case. That also is a pointer that it is a bilateral superior oblique palsy.
Also the head position.
Yes, also the head posture. Yeah.
One question which the postgraduate usually asked is, if you have a third nerve palsy, how do you actually detect whether the patient has a fourth nerve palsy or not? Dr. Mahesh, you would like to say on that?
Yes. So one of the common questions is in the presence of third nerve palsy. So when the PGs answer this question, sometimes they are confronted with the question of how will you test a normal fourth nerve palsy? Fourth nerve movement. So we have been constantly teaching them how to test a fourth nerve palsy in the presence of a third nerve palsy, and in such situations, sometimes the PGs may forget to tell what is a normal movement of the fourth nerve palsy. So first, always the residents should remember how do we normally test the fourth nerve, which is depression in adduction. And then in the presence of a third nerve palsy, what do? Is there is no adduction, so we cannot test it in the test the depression in adduction. So you look for the primary action of the superior oblique, which is fourth nerve, which is intorsion, and which is best detected in the abducted position. Look for, as a patient, to look down and check for the intorsion, and it is best seen in that position because of the alignment of the globe in the abducted position.
And a lot of times examiner would ask or examiner would expect you to say that you look at the vessel, because that's how it's
Yes.
so they'll expect you to say that look at the vessel, and then the vessel will turn in and there is an intorsion, and that's how you demonstrate.
Sometimes we can look at the fundus torsion also, or even on slit lamp. So,
preferably the vessel torsion, vessel intorsion is seen in the slit lamp, preferably.
Fine. We can go to our Dr. Chitra, you want to ask any other question?
No. I think everything has been covered. There's one question which I had. When do you suspect a masked bilateral fourth nerve palsy?
So, see, this is again, we usually look for the amount of torsion on double Maddox. Usually, a bilateral is masked. You can mistake it for a unilateral, but if the torsion is large, then you suspect a bilateral.
And in that, the vertical alignment will be much less. So you would not have a very high hypertropia, but more of torsion. That's the way to detect a bilateral. So then we go to our next talk, which is going to be by our speaker, Dr. Love Kochkave from Kolkata. He's a director of Netralayam and the executive director at BB Eye Foundation and director at the SLR Eye and Retinal Surgeons. He has extensive experience in handling complex and challenging surgeries and good academic contribution. He'll be talking on managing 6 nerve palsies. Over to you, Dr. Love.
Thank you so much. And thank you, ma'am, for giving me this opportunity. Is my screen visible?
Yes.
So I would be speaking on 6 nerve palsy, and so one important thing is that this is the most frequently involved cranial nerve palsy because of the long and tortuous course, and as it's located in the peripheral part of the nerve near the clivus as it enters the cavernous sinus. So any kind of elevated intracranial pressure from any cause may lead to a 6 nerve palsy. Etiology wise, as we all know, in adults, the most common is the microvasculopathies and related to hypertension, diabetes, and the other causes may be infections like Lyme's disease, arachnoiditis, trauma. Any kind of trauma may lead to a 6 nerve palsy, neoplasm, and other causes like giant cell arteritis. But in children, again, the most common cause is viral infection. So etiology wise, when an adult presents with a 6 nerve palsy, first thing we look for is the diabetes and hypertension. And in children, we ask for history of fever. Other causes could be, again, trauma, neoplasm, and elevated intracranial pressure. So as Dr. Randhir had mentioned, in 6-nerve palsy, because the overaction of the medial rectus, it is causes uncrossed diplopia, and it is worse in the direction of the palsied muscle. Suppose, for example, if there is a right 6-nerve palsy, then when the patient sees towards the right side, then the diplopia worsens. And the face turn would be towards the right side because of the overaction of the medial rectus. So the patient maintains a right gaze to avoid the double vision. And esotropia in these cases are mainly due to unopposed action of the medial rectus muscle. There is limitation of abduction of the affected eye. And as in all other paralytic squints, secondary deviation would be more than the primary deviation. So just a case scenario in which we can see this is a right 6-nerve palsy. Now, again, important is how do we differentiate between a partial 6-nerve and a complete 6-nerve palsy? And this is again very important in adult cases. Most of the times in a partial 6-nerve palsy, the eye may be able to go beyond the midline, but if there is contraction of the medial rectus, then that may not be there. But in complete 6-nerve palsy, in no situation it goes beyond the midline. Fourth generation test will be reduced in partial 6-nerve palsy, but absent in a complete 6-nerve palsy. Similarly, for duction test, unless there is a contraction of the medial rectus, both the cases there will be no restriction. Saccades partial will generate, but the complete one will not generate. Investigations, again, in adults, first important investigation is the routine blood test, the blood glucose levels and ESR. If that is normal, and if you are thinking of neuroimaging, then the patients in which, especially if they present young, again, if this was discussed earlier also, in young presentation, it is better to do neuroimaging. If it is associated with other cranial nerves, that is again important. Association with pain, we have to do it. If it is a bilateral 6th nerve, it's always better to do a neuroimaging. And if it is associated with optic nerve edema or cancer. And what we do is with contrast. This is very important. How do we differentiate a unilateral lateral rectus palsy with the different other presentations like congenital fibrosis syndrome? Again, congenital fibrosis syndrome can be a bilateral, but the differentiating point will be the force duction test, which will show restriction. In Duane's is one of the common differential diagnosis. In primary gaze in Duane's, the esotropia will be less when compared to a lateral rectus palsy. Most important is the retraction of the eyeball on medial gaze. And once we do a force duction test, sometimes it may give a paradoxical result. Graves' ophthalmopathy, again, the history of thyroid will be there, and this can cause abduction deficit also due to the thickened medial rectus muscle. Entrapment of medial rectus is another differential diagnosis in which there will be a history. Obviously, the history of trauma will be there. Force duction test is again differentiating factor. And neuroimaging will show entrapment of the medial rectus. When we differentiate this with myasthenia, most important point is the fluctuating, the readings will not always be the same and may be associated with ptosis. Strabismus is variable, and then finally the diagnostic tests will confirm the diagnosis. Other differential diagnosis would be excessive lateral rectus recession for squint, that is post squint surgery, or a disinsertion or slippage of the lateral rectus. Again, in this case, history is there. History will be present. In case of bilateral lateral rectus palsy, the most common differential diagnosis would be the infantile ET, and most often it is infantile ET rather than a bilateral lateral rectus palsy in infants. And how do we differentiate this? When we cover one of the eyes, there will be a clear abduction movement.
It's 7 o'clock.
And in the doll's eye movement, that will elicit abduction. Horizontal gaze palsies, again, lack of ability to generate binocular, saccadic, and pursuit movements to some eccentric orbital position, and abnormal head posture will persist on monocular occlusion. Graves ophthalmopathy, again, the history of thyroid will be there, and forced duction test. Now coming to management, in children up to age of 4 years, the aim is to prevent amblyopia and preserve binocular fusion as far as possible. And most of the times, because it is a self-limiting condition, alternate occlusion will help both in preventing the diplopia and to prevent secondary contracture of the medial rectus. But for small deviations, we can give base out Fresnel prisms. And if the child loses binocularity, sometimes if it is a prolonged sixth nerve palsy, then chemo denervation of the antagonist medial rectus may be tried. Similarly, in adults, if it is associated with hypertension or diabetes, first 6 months we just observe, and the important instruction to the patient is to control their general health parameters so that recovery can be better. And during that period, again, we can do alternate eye occlusion. What I tell my patients is that when they are indoors, then occlude the normal eye. And when they are outdoors, then occlude the affected eye, because then chances of bumping into objects and accident would be there. So for the that time period, we can try alternate occlusion. But when surgery, suppose if it is persisting for more than 6 months, then we have to correct the concomitant ESO deviation by surgery to improve the abduction and increase the size of the centration of diplopia-free binocular field. That is, we aim for diplopia-free vision in the primary gaze. And as for any other squint surgery, FDT is a must when we are planning a surgery. Now coming to the surgical planning, depending on whether it is a partial or a complete third nerve palsy, if it is up to 20 prism diopters of deviation, then we can, the choice is either only lateral rectus, the lateral rectus resection is done. If there is a coexisting medial rectus contracture, which we will know with forced duction test, then medial rectus recession along with lateral rectus resection. And if it is more than 40 prisms, then the contralateral medial rectus recession along with RNR. Now in partial, there are various, in total 6 nerve palsy, there are various transposition procedures available in which we can have a partial or complete transposition of the superior and inferior rectus, or muscle union procedures like Jensen's procedure. Complications, again, vertical deviation, anterior segment ischemia, say if there are more than 3 muscles involved, and undercorrection and overcorrection. Role of, one thing we have always debated, role of botulinum toxin for the for lateral rectus palsy, and sometimes botulinum toxin actually helps when we inject in the medial rectus muscle to prevent contraction. And it allows operation of only 2 rectus muscles, decreasing the risk of anterior segment ischemia. But again, for practical purposes, there may be other problems associated with the botulinum toxin, as if the toxin leaks to other muscles. Thank you so much.
Thank you very much, Dr. Love. That was very precise and complete. I'll just ask one small question before Jyoti takes over. You did talk about botulinum toxin, but you said seem to combine it during surgery. Non-resolving 6 nerve palsy, would you think of using Botox as a temporary measure?
Temporary measure, logically speaking, in the initial first 6 months, it may help. But when surgery is required and we have crossed 6 months period, then I don't think Botox will help. Then it has to be a pure surgery.
So in the waiting period before, like the patient comes and it's not a diabetic and it's a young patient, would you give botulinum toxin to them? Say within a month if the patient is reported?
That was my question.
Practically speaking, I
Yes.
don't
We usually do. It can be done in the outpatient by just lifting up the medial rectus and injecting under it around 2.5 to 5 international units of Botox. It's usually practiced by strabismus squint specialists.
Right. I've also given, and I've seen that in the initial, especially when we know it's not a diabetic, because in those cases it tends to resolve very easily. But if it is not, if you give it, it tends to help in early resolution, especially in young post-trauma can be tried.
Yes.
One other question, Dr. Sujata, I want to know, in cases where we know a very frank DRS, obviously we know there's a retraction and we can easily differentiate between a sixth nerve and a DRS. But in case where we don't have a frank retraction happening, is there some other signs that we can look at to figure out if this patient is a sixth nerve or not?
You can have down shoots which may be associated. You can have the force duction test, which may be a little force generation test, which may be a little different from that of the lateral rectus paresis. Plus, definitely palpebral figure changes are quite prominent. Plus, the angle which you have in DRS is usually small. If you see the abduction limitation versus the angle of deviation does not correlate. So if you have an abduction limitation of -3 or 4, you will actually expect in a lateral rectus paresis to have an angle which is large, 30, 40 prisms or so. In DRS, surprisingly, contradictorily, it is not so high. So it's a small angle with a large abduction. That gives a pointer.
Yes, I think that's a very good point to say. Yeah, Dr. Rashman.
The most important thing is in advanced retraction, they won't have diplopia, no? That itself is the thing.
Yes.
Yeah, they tend to have a face turn, right?
Yes.
Yeah, Dr. Rashman.
Yeah, so just wanted to add 2 more points from the exam point of view for these. There are 2 regions during the course of sixth nerve where it is in proximity with the seventh nerve. One is in the pons, the nuclei are together, and second is at CP angle. The way you can differentiate by clinical examination at these 2 locations is that if there's a lesion in the pons where the nuclei are involved, then with the seventh nerve, there'll be gaze palsy because the sixth nerve nucleus with PPRF acts as a gaze center. It controls the gaze to the same side. In CP angle tumor, sixth and seventh both can go, but the other eye adduction will be normal. You may find nystagmus in the other eye because if there is a concomitant involvement of cerebellum as well, then you will find that adduction is normal, but there is a nystagmus.
Dr. Prem, one question. What would be your management if you have a multiple cranial nerve involvement, right? We discuss individually, but if you have a patient with having third, fourth, sixth, or combination, how would you go about for the students?
That's a real challenge. That's a difficult situation to try to control. I think a combination of selective Botox to particular muscles as well as prisms is usually my way to do it. Surgically, it's very challenging to try to have a good field of single binocular vision in those patients with multiple cranial nerve palsy. And as Rashman just mentioned, don't forget 5 and 7. Those patients often may have a neurotrophic cornea as well. And so you need to be very careful in ensuring that that is protected.
And one question regarding prisms, you mentioned what sort of prisms would you give and which kind of palsies would you advise prisms?
So I tend to use the temporary prism, the Fresnel prism, so that it can be adjusted very easily. And it's often putting prism onto the normal eye that works a little bit better to try to shift it toward where the paretic eye is sitting. And so fourth, it's hard, as was mentioned earlier, because of the torsion, it's hard to correct that. But with third or sixth, with an appropriately obliquely placed prism, I've found that can be very helpful. And again, that's why the temporary prism is helpful.
Yeah. Just to mention what Dr. Prem is talking at the Fresnel's prism, these are stick-on prisms that you get just for the postgraduate, which you can stick onto the glasses and you can peel them off whenever you want.
Yeah, thank you.
Yes, Dr. Jaspreet, right.
Shall we go on to
Dr. Chitramanu, Dr. Jaspreet wants to say something here.
I just want to add on, in children, when you see a sixth nerve palsy, I mean, it's very important to rule out a slow-growing tumors. Imaging is a must. And the other thing is history of vaccination. You have viral sixth nerve palsy as well. So this is very important when you're dealing with children with 6 nerve palsies.
Okay. Yeah. Thank you. Yeah, Dr. Chitra.
Yeah, we go on to our next speaker. Dr. Shikha Masi is our next speaker, who is the Deputy Director of the Department of Neuro-Ophthalmology, Shankar Netralaya, and is also in charge of Navasuja segment. And she's, of course, had numerous awards and accolades for her varied contributions to ophthalmology and is our coveted speaker. So she is going to tell us in 10 minutes on disorders of pupil, which is going to be very challenging, but I am sure she'll bring out all the take-home points for the postgraduates. On to you, Dr. Shikha.
Good evening, everyone, and thank you, Dr. Chitra, for this opportunity. Pupillary disorders include all this, but I'm going to cover the important points which I felt were important given in the red box. Now, the normal pupils are described by the acronym PERLA, which means pupils equal, round, and reactive to light in accommodation. Usually 2 to 4 millimeters in diameter in bright light, and in dark 4 to 8 millimeters. Now the iris dilator muscles are present radially and are under sympathetic control and cause dilatation benign. Whereas sphincter muscles are present circumferentially and are under parasympathetic control, lead to constriction of pupil. This parasympathetic control comes under the pupillary reflex. Let's see what happens. When we shine light in the left eye, the temporal fibers from the retina reach in the pretectal nucleus on the ipsilateral side, and the nasal fibers reach the pretectal nucleus on the contralateral side. Now the ipsilateral pretectal nucleus goes and stimulates both the Edinger-Westphal nuclei, and so does the pretectal nucleus from the contralateral side. So what is important is that when shining light, both the Edinger-Westphal nuclei are getting stimulated equally. Now, the third nerve starting from the nuclei, going to the ciliary ganglion on the same side, and then through the short ciliary nerves reach the sphincter pupillae and constrict the pupil equally on both the sides. So you're shining light in one eye and both the pupils are equally reacting to light. The same thing happens when we shine light in the other eye. Now the relevant sympathetic pathway anatomy. Here the first order neurons are starting from the brain, and that's in the posterior hypothalamus. From there, it goes to the ciliospinal center of Butch, that is at the level of C8 and T2. From there, the second order neuron reaches the superior cervical ganglion, and from superior cervical ganglion, the third order neuron starts and reaches, it goes inside the brain along the internal carotid artery and reaches the dilator pupillary muscle. Now, coming to the pupillary evaluation, we should look at the shape, size, and the reactions, pupillary reactions, which include direct and consensual reaction, relative afferent pupillary defect, and near reflex. Why do we do this? To look at the ocular and general health of the patient. These shape-related issues are actually related to the iris structural defects, as we'll see in the next slide. And size-related issues usually tell us more about the efferent pathway defects, and relative afferent pupillary defect tells us about the problem with the afferent pathway, that is optic nerve-related defects. Now, these are self-explanatory shape disorders of the pupil. Out of this, I would like to tell you something about the aniridia. It is an autosomal dominant condition due to a defect in PAX6 gene. And if there is no family history of aniridia and a child is born with aniridia, it's prudent to do the surveillance for Wilms tumor, which is seen in, which could be seen in these patients till the age of 8 years. Now, let's come to the pupillary disorders of the size. Anisocoria refers to a difference in the pupil size of more than 0.4 millimeter between the two eyes. If it increases in dark and the patient has ptosis in the eye with the small pupil, you're looking at Horner syndrome. If it increases in bright light and the patient has ptosis and motility abnormality in the eye with the larger pupil, you're looking at third nerve palsy. And if there is no ptosis and no motility abnormality, probably the patient has AD syndrome. It could also be a physiological anisocoria, that is, if it remains the same in dark and light, but it's usually less than 1 millimeter. Now, unilaterally dilated pupil can also be seen in traumatic mydriasis, in rubeosis, and if you have put some dilating drop. Similarly, unilaterally miotic pupil could be a physiologically small pupil, or could be seen in uveitis or because of the pharmacological constriction. AD stonic pupil is typically a unilateral mydriatic pupil, commonly seen in women, and it's because of the denervation of postganglionic supply to the sphincter pupillae and the ciliary muscle, which usually follow a viral illness. What happens when we shine light on AD's pupil? We see vermiform movements of the pupillary border because of the segmental contraction of the iris sphincter. The near reflex is usually normal, but the redilatation after the near response is slow. And over a period of time, the AD's pupil becomes miotic when it's called little old AD. And when we have diminished deep tendon reflexes along with AD's pupil, it's called Holmes AD syndrome. And if there are disturbances of sweat secretion, it's called Ross syndrome. How do we confirm the diagnosis? Since we said there is a denervation, there is denervation supersensitivity, which is elicited by putting dilute 0.125% pilocarpine. Because of the supersensitivity, the AD's pupil constricts and the normal pupil does not. There's no particular treatment for this condition. The accommodative response improves over a period of time. It's important to reassure the patient. Now, coming to the Horner syndrome, we've seen the anatomy of the sympathetic pathway. If there is any lesion along the oculosympathetic pathway, the patient can have meiosis, ptosis, and hydrosis. The signs can be really subtle. The partial ptosis is because of the paralysis of Muller's muscle, and in the near and light reactions, there can be a dilatation lag, and there's an apparent inophthalmos because of the slight elevation of the inferior eyelid as a result of weakness of inferior tarsal muscle. And hydrosis is seen only in the lesions below the superior cervical ganglion. Now, how do you confirm the diagnosis of Horner syndrome? You can use 4% or 10% cocaine eye drops, which block the reuptake of the norepinephrine released at the neuromuscular junction, and the normal pupil dilates, whereas the Horner's pupil does not dilate. If you don't have cocaine, you can use 1% apraclonidine. It's a weak alpha-1 agonist. We've seen the denervation supersensitivity in ADs. Similarly, here there is a denervation supersensitivity because of which the Horner's pupil dilates and the other pupil does not, normal pupil does not dilate. How do you localize the lesion? You can use 1% hydroxyamphetamine eye drops. They act by releasing norepinephrine at the presynaptic terminal. So if the postganglionic neuron is dead, then obviously it will not dilate. Hence, if the pupil is dilating, then you can localize the lesion to the first or second order neuron. Now, dissection of internal carotid artery can be a devastating condition and can present as Horner syndrome, especially painful Horner syndrome. Let's look at this case, a 46-year-old male who came with burning sensation on the right side of the face with some vague complaints of decrease in vision. He actually didn't have any decrease in vision. What he had was an anisocoria of 2 millimeters. As you can see, the anisocoria was more prominent in dim illumination. The ptosis was very subtle, around 2 millimeters. And on the basis of these findings, a diagnosis of Horner syndrome was made. Patient was sent for MRI with MRA of the head, neck, and chest. And we found the dissection of the distal cervical internal carotid artery. Patient was sent to the interventional radiologist, started on oral antiplatelet agents, and a stroke was averted. Now, if an adult presents with the same features, that is ptosis, meiosis, and hypochromic heterochromia, and is asymptomatic, then you have to ask for older photographs and look for the ptosis and meiosis, which has been there since early childhood. In such a case, you don't have to order very elaborate investigations for Horner's because you could be seeing a case of congenital Horner's. Now, people involving third nerve palsy could be harboring important lesions like a PCOM aneurysm, and neuroimaging is a must. It can also present as multiple cranial nerve palsies. That is, pupil involving third nerve palsy can have a fourth, fifth, sixth, as seen in this case with herpes zoster ophthalmicus, and the lesion localizes to spheno-cavernous area. You can also have pupil involvement in a sixth nerve palsy. Usually, it is a constriction of the pupil that is seen because of the associated Horner syndrome with sixth nerve palsy. Here we had a case where the pupil was dilated, but nonetheless the lesion localized to the same place, that is in the cavernous sinus. Now, this is my last slide. We should know how to elicit the relative afferent pupillary defect. We will go back to the initial anatomy slide where we saw that when we shine light in one eye, both the third nerve nuclei are equally getting stimulated, hence both the pupils constrict. So if the whole pathway is working properly, that is, optic nerve is a part of that pathway. So if it is working properly, both the pupils should constrict. Now here, the left eye is normal, right eye has got optic nerve lesion. We shine light in the left eye, both the pupils are constricting. We shine light on the right eye where there is a defect, both the pupils are dilating. This dilatation is what is happening is there is no constriction occurring here, but the dilatation is because of the withdrawal of this stimulus. So what is happening is this is a swinging flashlight test which is done to diagnose relative apparent pupillary defect, and the eye with the optic nerve damage, that pupil dilates. So there are a lot of points in pupillary disorder which are from the exam point of view important, but I haven't covered. You should go through all these. All the best.
Thank you. Thank you very, very much. That was a wonderful talk, Shikha. Really enjoyed it. So I'll ask one question before Jyoti takes on. When can you have RAPD? Since you talked of RAPD in the end, when can you have RAPD without a problem in the retina or in the optic nerve dysfunction?
When there is a lesion in the pretectal, that is pretectal, unilaterally you have a lesion. This is a gold medal question probably. So if you know that usually the pupillary pathway fibers are going with the optic tract, but they leave the optic tract at the before the lateral geniculate nucleus to go to the pretectal nucleus. So if there is damage there, you could be, you've got a normal optic nerve, but you will still have a relative apparent.
Yes, Dr. Mahesh.
Yeah, just to add to Dr. Shikha's point that this RAPD is on the opposite side of the optic tract lesion because majority of the fibers are crossing here for 52% versus 48% uncrossed. So this RAPD is on the opposite side of the optic tract involvement, just to add to her point.
And to add, you can also have RAPD in very dense amblyopia retinal detachment, all of them can also give rise to relative afferent pupillary defect.
One important question for the postgraduates is that when there's only one working pupil, how do you test RAPD? So I think anybody, Rashmin, you want to take?
So I think there are two aspects to it. When you have one working pupil, that means the other pupil, as what Shikha has shown, and beautiful presentation, Shikha, is that other pupil is damaged or atropinized or it's stuck or just an empty socket, enucleated eyeball. So let's talk about enucleated eyeball. Technically, when you're looking at one eye and the other eye is empty socket, it's not RAPD because there's no relative, there's no other pupil. But the test which is sometimes asked in as a short note or as a viva is pupil cycle time, which is tested on a slit lamp. There is a horizontal beam of light which is thrown in the inferior part of the pupil. When the line goes through the inferior half of the pupil constricts. Now there is no light going through the pupil, it dilates. Light is going through, it constricts. No light, it dilates. So when this happens, and you are supposed to sit on the slit lamp and count how many times this happened in a minute, and there is a number which often I'm forgetting, but if it is more than a given number, then you know that patient has an optic nerve damage, and that's the reason why pupil is involved. And otherwise, Shikha has covered the other part where there is only one pupil, where there is a corneal opacity. You can keep looking at the eye which is available to you, because in swinging flashlight test, you are only looking at the eye which is illuminated, not bothered about the other eye. You see what happens to the eye which is illuminated, and you'll get the inference.
I think, Dr. Chitra, we can go to the next topic.
Yeah, you will have to introduce.
Oh, no, you're introducing Rashmin.
Oh, we have already introduced Dr. Rashmin. So Dr. Rashmin has been so magnanimous. Dr. Rohit had to go somewhere urgently. So he's come in just with a day's notice and is going to give us a wonderful, mind-blowing talk. On to you, Dr. Rashmin.
So first of all, formally, thank you, ARC, Dr. Chitra ma'am, and the entire team for involving me in such a beautifully crafted program. And Rohit was supposed to speak about management of acute loss of vision. Now, management of acute loss of vision is 60% of neuro-ophthalmology. So I'm just going to cover as to approach to see a patient with acute loss of vision. And as a resident, encounter this either as a theory question, you can be asked as whenever you can be given a scenario of a particular person presenting you with an acute loss of vision, or you can have a patient in your practical exam, in your clinical exam, with an acute loss of vision. So the whole idea of this is, what are the tests that you'll perform in the clinic? How would you quickly have an algorithm to find out what this patient might be suffering from? So this is what a typical scenario you may enter, either in a theory or whatever. A 24-year-old female with an loss of vision, vision in the affected eye is 624, fundus is normal in both the eyes. What would you do next? So right now, in this first segment of the talk, we are dealing with monocular loss of vision. First thing first, your question obviously is this a visual pathway lesion? That is question number one. And two, what would have caused it? Since this is a neuro-ophthalmology seminar, we assume segment exam is normal and the retina is normal. So how do you conclude to confirm that this is a visual pathway lesion, visual acuity? And this can be a separate short note. Optic nerve function test can be a separate short note for you. And this is the list of an optic nerve function test: visual acuity, pupils, relative afferent pupillary defect, which Shikha has covered so beautifully well, color vision determination, dyschromatopsia is a sign of an optic nerve lesion. It can give you a clue as to what has caused an optic nerve disease. It is often said that optic nerve inflammation causes a disproportionate loss of color vision versus ischemia, where the color vision loss is parallel to this Snellen's visual acuity loss. Visual fields, in a practical setting, you will do it with confrontation, apsilar charting, and with a red target, by a formal fields to confirm what you found: brightness sensitivity, contrast sensitivity, and examination of fundus. Now, the question is, how do you approach a patient with an optic neuropathy? First step first, you confirm that this is an optic neuropathy. You go back and say, how do you differentiate now what would have caused the optic neuropathy? Age, pediatric patients can have a different set of problems. If patient comes to you in a pediatric age group and has an optic neuropathy, it can be either a congenital optic neuropathy, or it can also be inflammation of optic nerve. And more often than not, in a pediatric age group, this inflammation will be because of infection. Below the age of 35, traditionally it is said that optic neuritis is a disease of a younger age group. Generally, the patient would be below the age of 35. Between 40 to 65, you're more, if the patient has optic neuropathy, you're more likely to be dealing. The first differential would be non-arthritic anti-ischemic optic neuropathy. Above the age of 65, your first differential is arthritic anti-ischemic optic neuropathy. Though one has to say that newer entities like NMO and MOG, this has become a little topsy-turvy because NMO and MOG can be seen even in the middle age or age group outside what is traditionally described as causing optic neuritis. The second point you asked in a history is fellow travelers. What are the other symptoms? And this is just a list of symptoms or features that you'll ask for. Does he have pain associated with acute loss of vision? What is described in literature as typical optic neuritis, 80 to 90% of those patients will complain of pain. And that pain, generally they will describe, it gets aggravated by eye movement, especially when they look up. Fever tells you that optic neuropathy or optic neuritis may be because of infective cause. Limb weakness, bladder bowel dysfunction tells you that there is an associated neurologic disorder. It can be seen in multiple sclerosis or even in NMO. Hiccups. In India, we are seeing more and more patients with optic neuritis who are because of neuromyelitis optica. And one of the symptoms which is associated with MO, can be associated with NMO, is hiccups. Skin lesions and respiratory problems will tell you whether the patient has a concomitant autoimmune disorders or sarcoidosis or tuberculosis. Again, same goes with joint pains. Weight loss can be seen in somebody who has autoimmune disorder, GCA. Vasculopathic risk factors tells you if patient has hypertension, diabetes, dyslipidemia, which is not controlled, you know that you might be dealing with ischemia of the optic nerve. Smoking, alcohol, medication will tell you that you might probably dealing with toxic optic neuropathy, though they don't routinely present in an acute form. So in other words, first step when you are dealing with an acute loss of vision, monocular acute loss of vision, first you say that, yeah, this is an optic nerve problem. Second, you ask those history points. You are asking those history points because this is the differential diagnosis. The commonest two optic neuropathies which comes to you with an acute loss of vision is optic neuritis and anti-ischemic optic neuropathy. Toxic or nutritional optic neuropathy, methanol toxicity can come to you with an acute loss of vision, but generally that will be bilateral and the history would be there. Hereditary optic neuropathy, only form of hereditary optic neuropathy which can come to you with an acute loss of vision would be LHON, trauma, and compressive lesion. Generally, compressive lesion would cause a gradually progressive loss of vision unless a tumor which was sitting there for a long time and suddenly expands because of bleeding within the tumor, as can happen with pituitary apoplexy. Then the patient can come to you with an acute loss of vision, but that's last in the list. So the commonest optic neuropathy is typical optic neuritis. What is a typical optic neuritis? Optic neuritis which is associated with multiple sclerosis. What is the history of a typical optic neuritis? Patient will come to you with an acute loss of vision with pain. Vision goes down for first 2 weeks or so, stabilizes, and by 4 to 6 weeks, it improves. So this is a typical history of an optic neuritis associated with multiple sclerosis, associated with pain. A word about NMO, and this can be asked again as a short note because, as I said, in India, we are seeing more cases with neuromyelitis optica and MOG-related optic neuritis. So what are the features which prompt you to look for NMO? When the patient does not complain of pain, patient presents with disc edema. Remember, typical optic neuritis, 70 to 80% of these patients will be retrobulbar neuritis, while NMO patients will present with disc edema. Bilateral presentation is much more common with NMO versus a typical optic neuritis. They will have severe vision loss on presentation and they don't respond to steroids. There can be recurrence and other neurological deficits. What should we know about MOG? Similar spectrum as NMO, but more commonly associated with encephalitis. Probably this is much more bilateral than NMO, more likely to be monophasic, recurrence rates are low. It has a better recovery than NMO. MRI. In MRI of typical optic neuritis, you'll find that, so what kind of MRI would you order if you are suspecting optic neuritis? You should request for MRI brain and orbit with contrast with fat suppression. What do you look for? In typical optic neuritis, you'll find hyperintensity along the optic nerve and along periventricular area. In NMO, you'll find that this hyperintensity is continuing to the chiasm and even beyond. and areas which are generally not involved in typical optic neuritis, like hypothalamus, can be involved in NMO, while in MOG, you'll find that perineuritis, the sheath, is lighting up. So optic neuritis, what else should we know? And this is what you will write if you are just asked acute loss of vision. MRI is of prognostic indication, and as I described, it can also give you a clue as to what has caused optic neuritis. Steroids are mandatory now because of more incidence of NMO and MOG. Non-steroidal agents are required in NMO MOG to continue for a longer period of time, and disease-modifying agents like interferon are required for multiple sclerosis. These are the causes of atypical optic neuritis. The second commonest form of optic neuropathy. This is how you are answering if you're asked management of acute loss of vision or a short note is asked. The second common form of optic neuropathy which can cause acute loss of vision is anti-ischemic optic neuropathy. It can be non-arthritic, arthritic, or a rarely posterior ischemic optic neuropathy. What are points that you're supposed to know or highlight in this? What's the role of steroids? Controversial. There is a study by Sohan Singh Here which said that steroid might be useful, but it is not generally given unless patient comes in an acute phase. Sleep apnea, sorry for the spelling. So sleep apnea, smoking, and pharma associations like Viagra and amiodarone should be looked for, which can cause a syndrome similar to a non-arthritic anti-ischemic optic neuropathy. Arthritic iron, again, can be a short note, generally seen in an older age group. Painful loss of vision, features of GCA, should be admitted. AIOS-ARC should be done. Steroid should be instituted immediately to prevent vision loss in the other eye. Bilateral sequential, this can happen in LHON, mitochondrial inheritance. Disc appearance, you can find telangiectatic vessels which leak on FFA. Treatment options, gene therapy is being tried in LHON. Bilateral simultaneous vision loss, we're looking at probably chiasm or post-chiasmal visual pathway. Chiasmal acute loss of vision generally is because of compression. Bitemporal hemianopia will give you a clue that patient has a pathology which is near the optic chiasm. Other features like band-shaped optic neuropathy or nystagmus, seesaw nystagmus can be seen in chiasmal compression. Post-chiasmal, anywhere in optic tract, optic radiation. Generally, the commonest cause, pathology causing this problem would be stroke, vascular events, field, generally you will see homonymous hemianopia. So in short, loss of vision, first you'll perform the optic nerve function test to find out in a monocular lesion that patient has an optic nerve problem. In a bilateral simultaneous acute loss of vision, visual field will give you a clue as to what the patient is suffering from. Thank you once again.
Thank you very much, Dr. Ashmin. As usual, you are exemplary. Does OCT have a role in differentiating retinal from optic nerve causes of visual loss?
So more than differentiating between retina and optic nerve, I would say OCT is being looked at in the optic nerve itself. Let's say somebody who has a demyelination, you'll find that the other eye, fellow eye, which did not have a clinical, you might find that there is a thinning of RNFL. The other role of OCT in a loss of vision is to differentiate between true disc edema and a pseudo disc edema. And Shikha has a brilliant series, and very nice paper that she had presented, and if there's a time she can elaborate on it. So that's the role of OCT at the moment.
Dr. Shikha, you have anything to add?
No, I think that series is about differentiating between pseudo disc edema and true disc edema. But what I had published has been now refuted by there's a consortium now which talks about, the beautifully has, can directly visualize the drusen. Initially, we had said that the drusens appear as hyperreflective body. Now those are considered to be the axons, and the drusen is seen as a hypoechoic area. So what is important is for the postgraduates to know that on OCT, you can directly visualize the optic nerve drusens. And for the degenerative diseases, that is the optic, brain-related like Alzheimer's and the retinal nerve fiber layer thickness can give you an idea about the health of the retina and the optic nerve and the brain.
Dr. Jyoti?
Yeah, Dr. Prem, I think wanted to say something.
Yeah, just quickly, it's very important. Dr. Rushman's talking about acute vision loss, and it's important not to be fooled by a normal OCT of the retinal nerve fiber layer in acute vision loss. Retina can be very helpful looking for macular abnormalities, but the OCT can be completely normal in the setting of an acute optic neuropathy.
Any tips that you want to give to differentiate basically an acute true visual loss against this non-organic? So basically somebody is malingering. Any points that you want to give quickly to the students to differentiate?
Just quickly, I'll say that functional vision loss is a diagnosis that is made. It is not a diagnosis of exclusion. So you want to prove the vision is better. So if they're claiming NLP, use the large mirror and rock it to see if they follow. If they are claiming reduced unilateral acuity, put a face down prism in front of a good eye and see if it splits the image, because that of course says that they're seeing out of both eyes, even though they say they can't see out of the others. So you must prove that it is non-organic or functional. Don't make that assumption.
So one other point is you make them sign. A lot of people believe that signing you need to see, so they don't sign properly, but actually signing doesn't need any vision sight. So that's another point you can put. Yeah, so I think with that, we'll go on to the next talk. I'd like to invite Dr. S. Padmavati as a speaker who will be talking on neuro-ophthalmic visual field loss. She's the Chief of Neuro-Ophthalmology Services at Aravind Eye Hospital from Tirunelveli, a leader in our own strength. Over to you, ma'am.
Thank you, Dr. Jyoti. Good evening, all. At the outset, I would like to thank the organizers for giving me this opportunity. The topic assigned to me is neuro-ophthalmic visual field loss. Per se, visual fields, they represent the extent of the visual field which is perceived by each eye. If you see, it is almost simulated to a hill of vision. You have a high peak point which corresponds to the fovea and a small crater or a depression which corresponds to the blind spot. Any alteration or affection in the visual pathway, it alters this island of vision. It could be in the form of any craters or a depression, or it could be submerged itself. So perimetry is the art of measuring the dimensions of the visual field. So why do you do a visual field? It is for a diagnostic purpose, to diagnose a condition before you do a neuroimaging, or for follow-up of the patients. You want to monitor the disease progression, or in monitoring the day-to-day activities, how far he could cope up with the field defects. So what is the goal of perimetry? It helps you to localize as well as lateralize the lesion and also quantify the lesion. As usual, you have two types of perimetry. One is the kinetic, where you have the moving stimulus, and the static, where you have stimuli of varying intensity presented at static points. The techniques include the confrontation, which is still holds good for bedside diagnosis in immobile patients, where you can pick up at least 75% of the neurological deficits. Still in some centers, you still have the Jerem screen, where in the illiterate persons, you can roughly do the field test. The Amsler testing is also another thing which measures only the central 10 degrees. The Goldman perimetry is one of the kinetic perimetry, where you have Roman numerals, where you have the numerals with the alphabets for the stimulus used. So what is this advantage? Here you have a reliable computerized static testing. This can be done with poor visual acuity. You can always detect the peripheral islands of visual field. And it is also used in the extreme periphery. Also, it helps you to evaluate the shape of the visual field effects. The main disadvantage is it is not reproducible. It is more technician dependent, and this is not universally available. The automated perimetry is a standard which is used across all the centers. This is more reproducible, objective, standardized and sensitive, and this is less technician relevant. So the key questions when you want to interpret a visual field is, first you see the reliability of the test which holds. Is the test normal or abnormal? This you can, in a neuro-ophthalmology, you can just see the grayscale to see whether it is abnormal or normal. Whether this field defect involves only one eye, is it monocular or it is a binocular, whether it involves both the eyes. Does it respect the vertical meridian? If binocular, whether it is homonymous. Homonymous means it is either the same side or whether both the sides. If you say right side field is affected, the right temporal or the left nasal is affected, this says it is homonymous. When it is heteronymous, it is either both the temporal or by both the nasal fields. When you see a field, if you see the field defect here, the right eye, when you put the fields, you have to put the right eye in front of your right field in front of the right eye and the left in front of the left eye, and the right eye temporal. This is the right way of denoting the visual fields. So as such, when you see in a visual pathway, you have the nasal fibers and the temporal fibers from the nasal retina. There is crossing over of the nasal fibers, which relays in the lateral geniculate body and which continues as the optic radiation to the visual cortex. When you in the visual pathway, there is always an inverse representation. Suppose you have a field defect in the nasal side, you have a temporal field defect. When you have a superior field defect, a superior fiber affection, you have an inferior field defect. This is represented all way through the visual pathway. So you could classify this as a prechiasmal, chiasmal and postchiasmal. Prechiasmal is one which pertains to the optic nerve. I am pertaining only to the acquired lesions of the optic nerve. Before that, you have to see the arrangement of the fibers in the retina. Or the visual, in the visual field, all the field defects corresponds to the fovea, not the optic disc. And you have the nasal fibers, temporal fibers, and the papillomacular bundle. So when you have a field which involves this, you have a nasal step. If you see this is superior, this is inferior. So it is, as I said, you have an inverse relationship. So this, when you have a lesion in this area, you have an inferior arcuate defect. When it involves the superior half of the optic nerve disc, you have an altitudinal field defect, which you commonly see in ischemic optic neuropathy. The papillomacular bundle affection causes a centrocecal scotoma, whereas the temporal aspect, you have nasal aspect, you have a temporal wedge-shaped scotoma. So in cases of bilateral disc edema, where it could be due to papillomacular edema or idiopathic intracranial hypertension, you commonly have an enlarged blind spot, or you could have a peripheral constriction. This is the commonest field defect you get in idiopathic intracranial hypertension. But when you see in cases of idiopathic intracranial hypertension, you have to monitor the fields, because this could give you a prognostic value when you have to intervene surgically. Suppose you have a field defect where you have a progression, constriction of the field, where there is progression of the visual field, that it indicates that the patient has a progressive visual loss. So this patient needs an immediate attention or a surgical intervention. Optic neuritis is one condition where you have a unilateral loss of vision with an RAPD. You can have a varying field defects. The commonest is a central centrocecal scotoma or an arcuate nerve fiber layer defects. So this is the article which gives you the various defects in the optic neuritis. So this was a paper which had seen in the optic neuritis treatment trial. The baseline, they had found that diffuse vision loss was the commonest finding with central and centrocecal scotoma. This is a case of unilateral loss of vision. This patient had a Leber's hereditary optic neuropathy where he had a centrocecal scotoma. In case of ischemic optic neuropathy, where you have a pallid disc edema with nor hyperemia on the other side, you have an altitudinal field defect corresponding to it. So here it is visual field abnormalities in non-atretic A1. He found that inferior nasal sectoral defect was the commonest defect when compared to a altitudinal field defect. Toxic optic neuropathy is one which we encounter in our day-to-day things. Drugs like ethambutol and also vigabatrin. The commonest field defect we encounter here is a centrocecal scotoma. And you also have a peripheral contraction of field and decrease for color objects. Moving on to the next lesions where you have a binocular field defects. This was a 43-year-old male who had a defective vision. His field absolutely in one eye was, he had a hemianopia, whereas the right eye germ screen was absolutely normal. But the Humphrey field analysis, the automated perimetry clinched the diagnosis where he had a field defect in the temporal superior quadrant. So this was you have a bitemporal hemianopia, which is irregular, which denotes it is in the lesion is in the chiasma. So this is an X-ray which shows an enlarged cella, and this was the imaging which shows a enlarged pituitary, so showing a pituitary macroadenoma. So when you as such, this has a compression, the infranasal fibers are compressed, and the field progression is always clockwise in the right eye. In case of pituitary adenoma, the same holds opposite in case of a craniopharyngioma. So you have infranasal fibers which are affected. So you have the densest involvement in the superior temporal quadrant. This is fibers where you have the affection in the knee of von Willebrand, where you have a junctional scotoma, or if you have only the isolated fibers affection, this you have a temporal hemianopia. A lesion affecting superiorly will involve the upper nasal fibers, where you have an inferior temporal defects. A lesion involving from the pituitary will affect the lower nasal fibers, which will have a superior temporal quadrant affection first. Macular fibers have a macular hemianopic scotoma. So a lesion here will have a blindness in one eye, when you have the angle of the eye, you have a junctional scotoma. When you have a lesion here, it is almost bitemporal hemianopia. When you have the posterior end of the chiasma which is affected, you have a bitemporal hemianopic scotoma. This you have to differentiate that from a centrocecal scotoma. This represents the vertical meridian, whereas the centrocecal scotoma doesn't respect the vertical meridian. When you have an optic tract lesion, you have a incongruous homonymous hemianopia. So this was a 15-year-old female who had a defective vision in the left eye. The fields picked out the diagnosis of almost there is a constriction of fields, involvement of the total eye in the left eye, and right eye had a temporal hemianopia. So this is the case of craniopharyngioma, where you have the this is the superior nasal fibers which are affected. So you have an inferior temporal. As I said, it goes clockwise, anti-clockwise in the right eye and clockwise in the left eye. So these are the different types of meningioma. One is the olfactory, one is the tuberculum cellae, and the sphenoidal cellae, which causes a bitemporal hemianopia. The differential diagnosis of bitemporal hemianopia would include tilted disc, high myopia, peripapillary coloboma, any optic neuropathy with centrocecal scotoma. But mind you, all these will not respect the vertical meridian and they remain static over time. The retrochiasmal pathway, it includes the optic tract, the lateral geniculate body, optic radiation, cerebral cortex. These produce a homonymous hemianopia where one side is affected. They are usually the homonymous hemianopia is always from the lesion of the occipital lobe. Usually it is secondary to ischemia. The other clues to isolate where this lesion could be because of the optic tract or visual hallucinations in case of temporal lobe, or hemisensory loss or spatial defects in case of parietal lobe. You don't have any neurological symptoms or signs when you have an occipital lobe. The commonest etiology is ischemia, and the involvement is mostly occipital. The radiations account for 32% and the lateral geniculate body account for 1.3%. The study by Zhang et al., they showed that usually the teaching is the congruosity increases with as you go posteriorly in the retrochiasmal lesions. Contrary to existing belief, 50% of optic tract lesions also produce congruous hemianopia instead of incongruous field defects. As I said, you have 47% uncrossed fibers with 53% crossed fibers. So if you have a left optic tract lesion, you have a right homonymous hemianopia with the RAPD on the right side and with a bow tie atrophy on the right side. So this is, you have an inequality of the pupils with large pupil on the side of hemianopia. You have a temporal pallor on the side which you have the lesion, and the right eye will show a bow tie optic atrophy. So the next,
can you conclude? It's 12 minutes.
Oh, I'm sorry. Okay, lateral geniculate body, you have a sectronopia. Mayer's loop, you have a pie in the sky, and parietal lobe lesions, you have in the pie in the floor. When you have a lesion here, you have a temporal crescent, and this you have a homonymous hemianopia. With this, you have a bitemporal homonymous hemianopic scotoma. Okay, in recognizing visual field defects, you have to look at both fields together and you have to correlate with other clinical findings. Don't overlook other causes of visual field. You have to find whether it is unilateral, you think of pre-chiasmal, bilateral, it is homonymous or heteronymous. Heteronymous, it is chiasmal, and homonymous, it is retrochiasmal. Thank you.
Thank you, Dr. Padmavati. That was a very intensely extensive talk. Very good. I'm sure the PGs would gain a lot from it. Dr. Jyoti, there are many questions which have been answered in a talk itself. Want to take a question or we move on?
I think we can just, one question is what specific this program do you advise for neurological fields and any specific this threshold, and what type of field do you advise?
I usually advise a 30-2 in case, because there's not much difference between a 24-2 and a 30-2, but only thing is the peripheral isopters, the temporal isopters are included here. I usually advise a 30-2. In case of any field constriction, I go for a 10-2.
Okay, right. But I think for exams, we can mention that probably we should advise a 120-2 specifically if you're looking at something to be in the periphery. Like, in those cases, we may have to apply. So depending on each condition that patient has, we can advise an appropriate field. Yeah, I think we can move on. Dr. Chitra, you can introduce the next speaker.
Yeah. Our next speaker is Dr. Jasprit Singh. He's an associate professor at the PGI Institute and doing pioneering work in cataract surgery in children with glaucoma and has a significant academic presence. On to you, Dr. Jasprit. Yes?
Please unmute yourself.
Dr. Jasprit?
Dr. Jasprit, you have to unmute yourself.
I just share the screen.
Yeah.
Yeah, can you hear me now?
Yes.
1 second, I'm just... Yeah, sorry. So first of all, I'd like to thank Dr. Chitra for this wonderful webinar. It's back to basics, and Dr. Rashmin and Dr. Padmavati have made my work much easier. So I'll be discussing something about the disc edema. It's unilateral and bilateral. So you see all these things. I mean, the residents would see them. I mean, you can have this just swelling of the disc. You have so many causes for these disc swellings. And it's so confusing when a patient comes with disc swelling, what exactly has he got? So it's ranged from inflammatory optic neuritis to poisonings, and the commoner ones like idiopathic intracranial hypertension. You have ischemic optic neuropathies, you have intracranial tumors. So there's just a whole lot of causes, I mean, which can cause the swelling of the optic disc. So you have so much morphological similarities in these appearances, so many causes. So how do we approach them? So first, we need to identify if we are dealing with true disc edema or it's a pseudoedema. So by pseudoedema, I mean it's a swollen disc, but not due to axonal distension or an edema. A true disc edema is disc swelling due to any other cause. A papilledema is usually a bilateral disc swelling due to raised ICP. So raised intracranial pressure when you have is the definition what papilledema would fit into. So points to consider when we decipher what we are dealing with. So first thing is, as I told you, is it a true disc edema or is it a mimicker? The second thing to know is status of the optic nerve function, which was discussed by our previous speakers. Associated findings in the form of exudates or maybe hemorrhages. So most important thing is don't use a direct ophthalmoscope, use stereoscopic viewing of the optic disc, either use a 90D or a 78D to identify. So the first thing you need to identify is whether it's a true disc edema or a pseudoedema. So a true disc edema would have characteristic symptoms like you can have acute visual loss, or you can have a kind of you can say inferior altitudinal field defect. Whereas in pseudoedema, they are usually soft signs. You have transient obscurations, or just the patient might come to know of a supposed field loss. Then the disc elevation. The elevation in true disc edema would extend beyond the disc in the form of patent lines when there is retinal edema. Whereas in pseudoedema, it's limited to the disc. The most important point in differentiating a disc edema versus a pseudoedema is the vessels are obscured in true disc edema. There's a normal branching, whereas they are never so in pseudodisc edema. There is abnormal tortuosity, there's abnormal branching, there could be trifurcation. So this is one of the most important points in differentiating a disc edema versus a pseudoedema. The color is usually hyperemic in true disc edema, sometimes pale as in ischemic optic neuropathy, wherein pseudoedema it usually retains its color. There's no hyperemia, there are no hemorrhages, no exudates. There is absence of physiological cupping. And of course, pseudoedema has, the causes are there, but they're a little less as compared to the gamut of causes in disc edema. So some of the pictures what I'll be showing you is pseudoedema. The first thing is the most common is disc drusen. Now these disc drusens can give the appearance of a pseudoedema. We can see here two refractile bodies here. These are the drusens. And similarly here where we are seeing the arrows are the drusens. So the best way to identify them is get an autofluorescence. So when they're superficial, the autofluorescence would show them. If they are deep, then what you require is what you call as the enhanced depth imaging on the OCT. If still in doubt, you can go for an FFA. The other thing to know is a congenitally tilted disc. This is a congenitally tilted disc with abnormal branching. You can see so much branching happening, and the vessels are emerging inferotemporally. This should not be. It should either be in the center or slightly nasal. So there is so much branching. The hyperemia is not there. There is absence of cup. So these are pointers in favors of a pseudoedema. Then you have myelinated nerve fibers, which are usually identified on doing a stereoscopic evaluation. So these are some of the things which one needs to be careful when dealing with patients of a pseudoedema. So what's true disc edema? Now true disc edema, you can see here varying stages. This is the early phase and this is the late phase. So there is a lot of hyperemia. There is peripapillary opacification. There is blurring of vessels at the margin. So this is early stage. So if you grade them, there's grade from grade 0 and goes to grade 5 depending upon the stage of severity of disc edema. So this grading is important in follow-up of the patients. Then you can have venous engorgement, which is visible here. And in late stages, you can have exudates, you can have telangiectasia, superficial hemorrhages are there, and patent lines, which you can see these fine radiating lines. So these are some of the identifiers to a true disc edema. The other thing is, when first we've identified whether it's true or a pseudoedema. The second important thing to know is what is the laterality, whether it's unilateral or bilateral, and optic nerve dysfunction. So optic nerve dysfunction has been covered. It would include visual acuity, RAPD, color vision, and central scotoma. Now the most important out of them is RAPD. You can have a normal visual acuity in optic nerve dysfunction, but have an RAPD. So RAPD is really a good pointer for optic nerve dysfunction. Color vision is the earliest thing to be affected in optic nerve dysfunction. So if you have a unilateral disc edema with RAPD, consider it as optic neuropathy. If you have unilateral disc edema with no RAPD, it could be pseudopapilledema or it could be asymmetric papilledema. If you have a bilateral disc edema with RAPD, it could be asymmetric optic neuropathy because you have RAPD. Then you have bilateral with no RAPD, it could be papilledema or a symmetric optic neuropathy. So when it's symmetric, probably you would have sluggish pupillary reactions, but no RAPD. So the broad classification of true disc edema is you have ocular causes, you have optic nerve causes, going back you have intracranial causes, and then you have systemic conditions. So if we tabulate the causes, we can do it unilateral causes of disc edema and bilateral causes. So in unilateral, you have optic neuritis, although it can be bilateral as well, asymmetric. You have anterior ischemic optic neuropathy, where you have an inferior orthoneutral field defect, a pale disc. Later on, initially it's hyperemic. You have granulomas of the optic disc, masses, infiltration of the optic nerve. Leber's hereditary optic neuritis in the acute stages can have disc edema. Then you have intraocular causes like uveitis, CRVO, and hypotony. Where in bilateral cases, papilledema is the commonest. You have idiopathic intracranial hypertension, atypical optic neuritis. You have intracranial masses. You have systemic causes like hypertension. So whenever you have papilledema, I mean, hypertension has to be ruled out. It can be an emergency. You have anemia, granulomatous conditions. You have toxic neuropathy as well. So it is important to identify this as optic nerve dysfunction along with the laterality of the disc edema. So investigation, what would you do? Now you've identified it's true disc edema. You know it's unilateral or bilateral. what would you do? Well, before sending for imaging, an ophthalmologist has an OCT available, which can be readily done. So it's a quick and easy tool to identify the RNFL, GCL status, or drusen's if you're dealing with a pseudodisc edema. After that, basically imaging. So if you have a bilateral disc edema, always brain imaging. Contrast enhanced MRI with an MRV to rule out thrombosis. You have masses, intracranial tumors presenting as disc edemas. You could have chiasmitis, ethambutol chiasmitis. You could have toxic causes. So in bilateral causes, always imaging, brain imaging, orbital imaging with cervical spine screening could be a part. Unilateral based on clinical finding history, like beautifully covered by Dr. Rashmin, the optic nerve lesions. You have a contrast MRI, brain with optic nerve cuts, and cervical spine screening to rule out optic neuritis. So the other investigations need to be tailored as per findings. You can do an EDI OCT, that's enhanced depth imaging, based on whether you suspect a pseudoedema, which are buried drusen's. Anterior ischemic optic neuropathy or vascular lesion, you could order an FFA. Fields are always to be done. They are helpful clues in AION, in papilledema, in LHON, and optic neuritis has been covered by Dr. Padmavati. Then after all these things, then if you have papilledema, what you do is a lumbar puncture. Lumbar puncture should not be done before imaging, or you might have herniation of the brainstem. So very important. And the other investigations, again, based on clinical findings, if you think suspecting an LHON, go for a gene panel. So I'll just cover two cases here. The first one is bilateral disc edema, and the second case would be unilateral. So this is a 34-year-old female. She has tinnitus for 4 years, headache for 2 years, variable blurring for 1.5 months. So these are very inconsistent things, but there is no actual loss of vision. So her vision is 6/6, both eyes, color vision is fine, everything is fine, pupillary reactions are normal, everything is okay. The posterior segment, when you examine, shows bilateral disc edema, more in the right eye as compared to the left eye. And so we have an enlarged blind spot in the right eye as compared to the left eye, because probably more of the disc edema. So when you have bilateral disc edema with no loss of vision, absolutely fine color vision. So basically this would fit into either an intracranial space occupying lesion, blockage of CSF flow. It could be idiopathic intracranial hypertension or thrombosis, whatever it is. I mean, something which is causing bilateral disc edema. So when you get an imaging done here with an MRI and features are suggestive of a IIH, which are partially empty cella. You can see here that there is a hyperintensity low down, but it's dark above there. So it's partially empty cella. You have a meandering optic nerve, which is tortuous. You have flattening of the sclera. You can see how the sclera is flattened here. It's flattened here. And you have transverse sinus stenosis. Now, this is not that significant, but all these features, then there is no intracranial mass, fit into the diagnosis of IIH. And so a lumbar puncture was advised, which was consistent with the diagnosis of IIH. So this was a patient of bilateral disc papilledema. Next is a patient, a 34-year-old young fellow, presents with sudden decrease in vision one day with brow ache. First episode, no complaints. His vision is 5/60 in the right eye. In the left eye, it's 6/6. He has right eye RAPD. There is medial grade 1. There's no vitritis. And when you look at the disc, it's swollen as compared to left eye. It's hyperemic. There is engorgement. You can see here some peripapillary opacifications as well. So this shows that what we are dealing is acute visual loss with an optic nerve dysfunction with disc edema. So again, the visual field was inconsistent. I mean, you have field effects. Left eye, because the right eye did not have vision, so probably we could not get a good field effect, good field. And the OCT, as I was telling you, this is something very handy, very useful we have in our clinics, which is so fast. I mean, so if you look here, it's all white here. So this shows there is some disc swelling, otherwise it would be green as is seen here. But of course, there are, you have to be careful, you're not dealing with some kind of a false interpretations. And the red part here shows there is some defect. The more important is when you have disc edema, probably that is the time these would show some kind, these would give fallacious results. But the ganglion cell result analysis usually gives you a good result. In the eye with a normal vision, that is left eye, you have ganglion cell loss, which shows he had some kind of a subclinical attacks earlier. But right eye, in the right eye, what we are seeing is that it's green. Now this could be again fallacious. He has a disc edema. Maybe there is a loss, and because of the edema, they are swollen up. So one has to be careful, but this just gives a clue what's really going on. So of course, we had to perform an imaging in this patient because acute visual loss presenting with optic nerve dysfunction. What we found was it was consistent with all these are Dawson fingers, which are consistent with the diagnosis of MS. And here again, there was hyperintensity just in two cervical spinal segments. You can see here hyperintensity of the optic nerve as well.
Dr. Jaspreet, can you conclude, please?
Yeah, just the last slide. So I would conclude here by saying that specific history coupled with careful examination of the disc can guide you to know what you're dealing with, whether it's true or pseudoedema. Optic nerve testing should always be a part of the examination, and along with laterality, help us in narrowing down our differentials. Investigations can help us in knowing the cause and just managing the situation. Thank you.
Thanks, Doctor, for a wonderful talk. But I think because of the paucity of time, we are going to keep your questions later. And Dr. Arul, I'll be very obliged if we hear Dr. Prem first, because I think he has to get into his OPD now. So I'm very sorry, but we are going to hear you your interesting talk. We shall now go on to Dr. Prem Subramaniam, and you're truly lucky to have him amidst us today, an individual of brilliance and standing. He's a vice chair for academic affairs and heading the neuro-ophthalmology department at the UC Health Eye Center in Aurora, Colorado. He holds joint appointments in neurology and neurosurgery and is the president-elect of North American Neuro-Ophthalmic Society. He's going to be giving the keynote address, and he's going to be detailing on understanding supranuclear disorders and of ocular motility.
Good evening, and thank you very much. And thank you, Dr. Arul, for kindly allowing me to go ahead, and Dr. Chitha for the invitation. So I'll be speaking about supranuclear gaze control and disorders involved in that. And this is a topic that has been introduced in part by some of the other speakers. And I'll start with a case presentation of a 68-year-old woman who collapsed at home. We saw her, she was transported to the emergency department, and a CT of her head showed a subarachnoid hemorrhage. She had a ruptured giant basilar aneurysm, so an arterial aneurysm affecting the brainstem, and she had emergent surgical clipping. And she was in coma for 3 weeks afterward. She recovered, and about 3 weeks later, awoke with double vision. It was horizontal, it was present at all distances and constant, and she was unable to look up or down, and she also had mild imbalance. So I don't have a video of her, but I have some videos I will show you later. Her afferent visual function was completely normal. Pupils normal, equal, extraocular movements were full, but she had absolutely no elevation or depression of either eye. She had full horizontal ductions, absolutely normal, and she had a very large angle exotropia. So in trying to localize where a patient like this has a problem, so a big exodeviation, inability to look up or down, and normal vision, and as well as some other neurological functions. Could this be a bilateral partial third nerve palsy? Well, as you heard, you should not have preservation of adduction if that occurs, and there was no pupil involvement, and she had no ptosis, so that didn't make any sense. It could be an orbital process, of course, but that did not fit with the history. You could do forced ductions if you were really suspicious of that. But among the other things you already heard from the other speakers about testing motility and testing for various ocular motor disturbances, what you should look for is you should look for saccades and pursuits. Can the patient initiate movements to the right or left or up or down? Do they initiate them quickly or are they slowly? And do they overshoot? Are they hypermetric? Or do they undershoot? Are they hypometric? And once they make the saccade, do they have difficulty holding the eye in that position of gaze? Similarly, with pursuit testing, both horizontal and vertical, a small target, move it slowly back and forth to truly test pursuit and not exceed the retinal slip velocity. Is the pursuit saccadic or is it smooth? Do they make little steps? And I'll show you some examples of this. Remember that the OKN drum is a nice way of testing pursuit as long as you don't rotate the drum too rapidly. So when we think of disorders of gaze, supranuclear disorders of gaze, the problem is generally going to lie in one of three places. It's going to be in the cerebellum, in the brainstem, or it's going to be cortical. Now, the cortical problems tend to be very acute and resolve quickly. And so what we'll talk about is primarily cerebellar and brainstem problems. So for the postgraduates, remember that you have frontal eye fields in the frontal lobes. You have the parietal or posterior eye fields as well. Both of these actually inhibit the action of the brainstem centers. So this is why damage in some of these areas can lead to overaction of the extraocular muscles, hypermetria. So that's your big clue often, is when the patient's eyes are moving too much, that suggests a supranuclear disorder, whereas nuclear or infranuclear disorders result in decreased movements of the eyes. Just a general rule that is helpful. The control of vertical eye movements is here in the midbrain, and control of horizontal eye movements typically arises from the pons. Dr. Rushman mentioned the PPRF, the parapontine reticular formation, which then has input to the sixth nerve nuclei, and I will show you how dysfunction of the PPRF leads to horizontal eye movement abnormalities. We'll start though with the vertical gaze centers, which are a little more complicated. You have the rostral interstitial nucleus and the medial longitudinal fasciculus, and they communicate with each other through the posterior commissure. Part of it, the lateral part, is probably responsible for up gaze, whereas the medial part may be responsible for down gaze. And this drawing does not really reflect the fact that the medial part may not communicate through the posterior commissure, but the upper parts do. So a lesion unilaterally of the RIMLF may lead to a total up gaze palsy, while you need to get both RIMLFs on both sides in order to end up with a down gaze palsy from supranuclear disorders. There is always going to be input from the vestibular nuclei as well, influenced by the cochlea. So don't forget about that as well. This is the basis of abnormal gaze in the setting of vestibular dysfunction. So we'll work our way from the bottom of the brainstem up but work our way back to the pons as well. So I'll start with a medullary dysfunction that you will classically see, the Wallenberg syndrome, with lateral medullary infarction. Non-ophthalmic symptoms include ipsilateral pain or temperature sensation impairment, a central Horner syndrome. You heard a beautiful talk on Horner syndrome. This is a first-order neuron problem that causes it on the side of the lesion. They may have limb ataxia and bulbar dysarthria or dysphagia. But what do we see as ophthalmologists? We may see that in the setting of vertigo, they may have nystagmus, but they may report a shift of the visual vertical. They may tell you the room is tilted or the room is even upside down. This is characteristic of Wallenberg syndrome. They may also show lateral pulsion, a sense that the eye or body is being pushed toward the side of their lesion. And they have hypermetric saccades on the side of the lesion, hypometric sides away from it. And they may show an elliptical trajectory of their saccades. And this gentleman demonstrates that very nicely. Watch as he looks up and down. See, and he's trying to look straight up and down, but his eyes deviate to the left side as he looks down. And this is classic ocular lateral pulsion. He's not trying to do this. This is involuntary deviation of his eyes toward the left side as he is making what he thinks are purely vertical saccades. So if you ever see this, look carefully for Horner syndrome, look for vertigo, ask the patient about vertical shifts in their perception of the world. Similarly, the ocular tilt reaction, I mentioned that can be part of the Wallenberg syndrome. What is this ocular tilt reaction? It is a manifestation of an abnormality in the otolithic optic pathways, so that cochlea is having output to the vestibular nuclei, and if your balance sense is off or the balance system is disturbed, there can be an abnormal response where the eyes do not tilt properly. Showing you an example of this. When we tilt our heads, there is normally a righting reaction where the eyes come back to the vertical so that the world does not look tilted to you. And that is shown here as this physiologic leftward ocular tilt reaction. The eyes are tilting back to the vertical when the patient tilts his head to the right. But when in this patient who has an abnormality, when he tilts his head to the left, the eyes are not able to rotate back center, and in fact, either rotate farther toward the left, or they just stay closer to the vertical, but they're actually pathologically going to the left instead of rotating to the right like they should. And what happens then? Your brain tries to compensate, and that attempted correction is what results in a vertical misalignment. This is a very complex subject. I don't have time to explain it in detail, and I recommend to all of you that you read the excellent papers by Michael Brodsky, my colleague at the Mayo Clinic, who has written beautifully on this. But some things you can remember: skew deviation shows that the lower eye is on the side of the lesion. So you have a vertical strabismus, but the lower eye is actually on the pathologic side. It may be comitant or incomitant, and it may mimic a paralytic strabismus, but it is a supranuclear disturbance of gaze. So again, you heard a beautiful talk from Dr. Digvijay about fourth nerve palsy. How can you differentiate a skew deviation from a fourth nerve palsy? It can mimic it because the patient may have a head tilt and head turn, just like in fourth nerve, but the torsion is different. The higher eye will be encyclotorted versus excyclotorted, as you will see in fourth nerve palsy. But that torsion may be hard to determine, and the patient may have trouble expressing that, or they may not have limited torsion. So there has been a fourth step of the Parks-Bielszowski third step test that has been suggested. And that third step, or that fourth step, sorry, is after you do the primary right and left and head tilts, you lay the patient supine. So this upright supine test, which is done where you think the patient may have a fourth nerve palsy, if you get a 50% or greater decrease in the vertical deviation, as shown in this graph on the right, that is much more characteristic of skew deviation than it is of a fourth nerve palsy or other causes of a vertical strabismus. So remember that when you see a patient who may have fourth nerve palsy, but maybe the history doesn't fit, or they may have some other neurological problems, tilt the chair back, remeasure the deviation. You can have them look at a spot on the ceiling, and that can help you to differentiate these things clinically, and tells you that patients with skew deviation need an MRI of the brain with gadolinium to look for stroke, tumors, or other potential causes of that skew deviation. We'll move now to midbrain lesions. The classic midbrain lesion from causing a supranuclear gaze disturbance is the dorsal midbrain syndrome. Compression of the posterior commissure. Remember, I told you that the RIMLF communicate with each other through the posterior commissure. The compression by a dorsal midbrain tumor or a pineal tumor leads to a combination of a paresis of upgaze, producing the so-called convergence retraction nystagmus, along with pupillary dysfunction, light near dissociation, eyelid retraction. Oculocephalic maneuvers are preserved though. So this was a teenager who presented with a pineal tumor. You can see that her horizontal gaze is completely normal. Now, when she tries to look up, she develops the convergence retraction nystagmus. You can see that her eyes are coming in toward the nose. They are not going up, even though she is trying to look up. So this is the classic convergence retraction nystagmus and upgaze paresis with attempted voluntary upgaze. But now, when I move her head, I can overcome that upgaze paresis, and her eyes move completely normally. This is what tells you again that this is supranuclear. The nuclei themselves are working just fine. I will skip over the pupillary findings. You had a lovely talk on pupil disorders already. Other midbrain lesions can give you nuclear or supranuclear disorders that produce paresis of vertical gaze. It may occur after infarction, after tumor compression, and upgaze, downgaze, or both may be affected. So unlike the dorsal midbrain syndrome that I just showed you that has the classic triad of findings, here you may see an isolated vertical gaze disorder. So this is an example of a patient who had a stroke, as I will show you, in the unilateral RIMLF. And you can see that this patient has completely normal horizontal eye movements as seen on the left, but on the right, he has a complete inability to look up or down. And this is caused by a lesion here. So this is an MRI of the midbrain. And on the right side of the midbrain, there is an infarction. This is structural, and this is DWI imaging showing restricted diffusion and an acute stroke in the RI-MLF, leading to an up gaze and down gaze palsy in this patient. And this is just histology correlating that lesion in the RI-MLF with the gaze paresis. I'm going to skip over this video in the interest of time and move on to supranuclear palsy. Progressive supranuclear palsy, a disorder you should be familiar with as an ophthalmologist, presents with deficits of vertical gaze, more often down gaze than up gaze. It may be the presenting or early symptom. Patients then go on to have difficulty with speech, motor control, and swallowing. And it is a difficulty with swallowing that unfortunately leads to aspiration pneumonia and frequently death within 6 years of onset of the disease. Treatment is not yet very effective, but these patients will have characteristic ocular motor signs: square wave jerks, saccadic VOR suppression, slow and hypometric horizontal saccades, and very slow vertical saccades. And I will show you some brief examples of these. So these are the square wave jerks, these little horizontal eye movements off target that affect these patients. Here you can see that they have a saccadic OKN. The patient is being turned around for a VOR and it does not work well. Here they have slow horizontal saccades, and here you can appreciate that they now have very slow upward saccades. See how long it takes them to initiate once they're told to move their eyes? It's just very, very slow. This patient is paying attention, he just can't move his eyes well. And then finally, very poor down gaze. This constellation of findings, highly characteristic of progressive supranuclear palsy. Finally, we can see that with disturbances in the pons of the PPRF and horizontal gaze centers, we can see a complete deficit of horizontal saccades. I will show you a patient with a complete horizontal gaze palsy. This is different from a nuclear sixth nerve palsy, because there you end up with a complete gaze palsy that cannot be overcome by vestibular movements or by oculocephalic maneuvers, but also the patient, if they have a lesion perhaps in the MLF, they will have a large exotropia. And I will show you two examples of this. But here you see that this is a patient who had a large tumor in the fourth ventricle. That tumor is present right here. And she had resection of this tumor. And this is, again, this is the back of the pons, the area where the PPRF lives. And there is, where the yellow arrow is showing you, some edema in the PPRF and some damage to the PPRF from the surgery. And so this patient now presented to me with a complete inability to look to the side. So she has absolutely normal horizontal gaze, vertical movements, vertical movements, up and down gaze, completely normal. But now she's going to try to look to each side. And when she tries to look to each side, she's trying to do something. And so she just moves her eyes up and down. She keeps moving them up and down because she has a complete inability to move up and down, to move side to side. But you can see that she has preserved convergence. She has preserved adduction. So this is not a nuclear sixth, because if she had a nuclear sixth, her abduction and adduction, the absence of abduction might also give her a large angle exotropia, as you might see in this patient here who has bilateral internuclear ophthalmoplegia. This was mentioned previously as another supranuclear, it's like an internuclear gaze disorder, a problem in which this patient had a stroke involving an area similar to the patient I just showed you, but he has a complete lack of adduction of each eye with preservation of abduction, another supranuclear or infranuclear gaze disorder that in this case is producing a fairly large angle exotropia. So looking back to the first patient I showed you, what did we learn from that case? She probably had a midbrain infarction, a combination of a bilateral nuclear third nerve lesion as well as a supranuclear gaze palsy. It may have spared the medial recti subnuclei bilaterally as well as the MLF, but these are complicated patients. And that's one of the messages I want to leave you with. Think about supranuclear gaze disorders and think about the various parts of the brain where they can occur. classically, midbrain lesions cause vertical gaze disorders, pontine lesions cause horizontal gaze disorders, vestibular lesions cause vertical gaze or cyclovertical disorders with nystagmus. But those rules break down because patients don't read the book. Their tumors can compress multiple structures. You can mimic infranuclear nuclear problems, and appropriate testing can help to sort out the causes. I thank you very much for your attention.
Thank you for an amazing talk, as was expected from you, Dr. Prem. Thank you so much. Any question, Dr. Jyoti?
Yeah, one question. How do we assess a patient with oculomotor apraxia? We see a lot of children with having that. Something that you want to, just mention what it is for the sake of the students, and how do we assess them?
Absolutely. For the sake of time, I didn't mention that, but oculomotor apraxia, especially in children, patients will use head thrust maneuvers. They will turn their head and then their eyes will follow in order to try to get their gaze to go into different positions. This there can be acquired oculomotor apraxia as well that has been described after thoracic aortic aneurysm surgery. And so it generally does not present anew in adults except in those isolated cases where patients have that history. And again, in children, I look for head thrust maneuvers and the ability that patients learn to overcome their problem that way.
And just end with some few points for the students about what are the specific things they should look when they look at supranuclear disorders. What are the points to differentiate them from the nuclear ones?
Absolutely. So again, in supranuclear disorders, the ductions are generally full. There is generally not a limitation of duction in any particular direction. And it is important that if you see a duction limitation, to always do oculocephalic maneuvers to try to overcome that apparent duction abnormality. Because if that oculocephalic maneuver makes the eyes move better than just asking the patient to move their eyes with either pursuit or saccade, that is one of your big clues for a supranuclear gaze disturbance. And then brainstem cerebellar lesions are often accompanied by either nystagmus, square wave jerks, or other cerebellar signs such as tremor or ataxia, or those other visual signs I indicated like a disruption of the vertical. So it's important to ask the questions about these other signs to see if they are present.
Okay, thank you very much.
Thank
Dr. Jyoti, thank you very much, Dr. Prem. I think thanks a lot for your presence today. Shall we go on to our next speaker? Dr. Jyoti, can you introduce him?
Yes, right. So we come to the last speaker for the session, and it's been a great feast for all, I guess, all of us also, and definitely for the postgraduates. I want to invite Dr. Arul Selvan, who's a consultant neurologist from KMCH, a leading multi-specialty hospital of Coimbatore, with an extensive exposure to top leading neurology centers of the world. And he'll be talking on a relevant topic of electrophysiology and neuro-ophthalmology. Over to you, sir.
Good evening. Many thanks for opportunity as given the opportunity by Dr. Chitra Ramamurthy and also Dr. Murali. Am I audible?
Yes, yes.
Okay. So this is a huge task for me to finish the electrophysiology and neuro-ophthalmology in 10 minutes. I'll try to do the justification. So first of all, I'm going to talk about the visual evoked potentials, and then second one is repetitive nerve conduction study, and the third one is single fiber EMG. The visual evoked potentials is the volume of impulses which are generated from the retinal nerve fiber and then carries through the optic nerve, optic chiasm, and optic tract, and then ended in the optic radiation. It is a summation action potentials. Volume of impulses are generated from this layer and could be recorded at the occipital cortex. It is similar to the other potentials which we record, like somatosensory evoked potentials from the median nerve, and brainstem auditory evoked potentials from the vestibular cochlear apparatus. So VEPs are the most common diagnostic pathway in the anterior vision pathway. Electroretinogram is useful in retinal disorders, which I'm going to discuss today. See, the volume of impulses usually generate from the nerve fiber layer of the retina. This is the thin layers of the retina. And then the volume of action potentials from the median cell taken from the nerve fiber layer, optic nerve, optic chiasm, optic tract, and further on in the optic radiation. The VEP tests the function of the visual pathway from the retina to the occipital cortex. It assesses the integrity of the visual pathway from the optic tract, and then it follows all the way up to the optic radiation in the occipital cortex. We all know that the temporal hemifield has been represented with the contralateral cortex in the occipital lobe, and then left hemifield in the right occipital cortex. The macula is represented in the occipital pole. So in the occipital polar reactions like the tumors, you will not get the macular sparing. So we discussed the left temporal field represented in the right occipital cortex, the right temporal field in the left occipital cortex. The P100, the most important component of the visual evoked potentials, are generated in the striate and peristriate occipital cortex. There are two types of visual evoked potentials. One is the pattern reversal visual evoked potentials, and the other one is the field flash evoked visual responses. The pattern reversal visual evoked potential is the contrast luminance acts as a visual stimulus, and then the action potentials are generated from the retinal nanofiber layer. So most consistent and reliable, it stimulates the macula and also represents the central vision, used almost all in neurology, neurophysiology laboratories. This is a typical example where the 1 meter in the front distance, then alternating checkerboard patterns are used. So 3 scalp electrodes are applied. One is median, nasion, and another one is the vertex. And before we apply, we check the impedance of the electrodes. And there will be a continuous averaging of more than 1,000 responses has been recorded, and then it's reproducible. So just as a schematic representation, this is from the occipital cortex, and this is acting as a reference, and this is at the ground electrode. This is a simple machine which we record through the visual evoked potentials. Flash evoked responses, which largely stimulate at the periphery of the retina, it's useful in certain clinical conditions we'll talk about, and then it's inconsistent. Unfortunately, it's not reproducible. So the pattern reversal visual evoked potentials are most reliable, reproducible, and always consistent. The flash evoked responses will indicate the function of the visual pathways integrity or not. When someone has got a very poor visual acuity, they cannot cooperate, they cannot look at the visual, the checkerboard pattern. As you see in newborns and young children, comatose patients, and also in cortical blindness. It has a wide variability. The latency differs from the P100 from 100 milliseconds to 150 milliseconds. So it's in general, the presence of flash evoked responses will indicate there is some anatomical integrity, whereas the absence of evoked potentials indicate complete interruption of the anterior visual pathways. Not only the stimulus factors are also responsible for the good visual evoked potentials. The pattern, the field size, whether you change it in smaller and bigger squares, distance at which the patients are seated, contrast luminance, and then rate of reversal. And the pupillary size also has the factors influencing the visual evoked potentials, age, alertness. If they're so drowsy and sleepy, you cannot get a good pattern reversal visual evoked potentials. Sedation and anesthesia abolishes the visual evoked potentials. So how do you diagnose? There are 2 criteria being used. One is a latency criteria, another one is an amplitude criteria. The latency criteria is there is more than 3 standard deviations from the normative data. For example, in P100, if you take it as a P100, 115 milliseconds is considered as up to the normal range. Beyond 115 milliseconds to 120 is considered as borderline abnormalities. Beyond 120 is definitely abnormal. And the amplitude criteria, as you know, that when there is an axonal loss, the amplitude will be smaller. So P100 latency for our lab or most of the lab, we derived these normative data from the normal controls, age and sex-based controls, and 3 standard deviations lies like this. So 115 to 120 milliseconds is considered as borderline. More than 120 seconds is definitely abnormal. Not only that, the inter-eye latency between the one eye and the another eye is also considered to be abnormal if it is prolonged for more than 15 milliseconds between the inter-eye latency. For example, if the right eye is 100, the left eye is 115, the left eye is considered to be an optic neuropathy. The amplitude, generally, if it is less than 4.5 microvolt, it's indicating axonal loss. So monoocular field stimulation, if an abnormality is seen on the before the eye, the lesion should be in the anterior to the optic chiasma. As we all know, beyond the chiasm, it decussates, and then the fibers decussates. VEP is normal in unilateral lesion of the optic chiasm with monoocular stimulation because the each cell projects into the occipital lobe. So P100 abnormalities, as we discussed earlier, that there could be 2 types of abnormalities. One is a delay in latency, another one is decrease in amplitude. All the demyelinating optic neuropathies will cause a delay in P100 latency because the myelin is important for the conduction. When the myelin is delayed, the conduction is slow. So that's why we get a prolongation of the P100 latency. Not all P100 latencies are demyelinating optic neuropathy. There could be something borderline abnormalities we all find in these conditions here: toxic amblyopia by alcohol and tobacco, and the vitamin B12 deficiency, anti-distant optic neuropathy, sarcoidosis, and Leber's optic atrophy, and then some hereditary conditions like adrenal and non-adrenal leukodystrophy, Charcot-Marie-Tooth disease, Friedreich's ataxia, and hereditary spastic paraplegia. The amplitude reduction, loss of motor responses, or loss of visual evoked responses, decrease in the visual amplitude is usually seen in traumatic optic neuropathy. And then the poor visual acuity also indicates that there could be a amplitude reduction. That's commonly we see in cataract, especially the mature cataract, and the retinal degeneration, severe refractive errors, and maculopathies also. VEPs are most useful in optic nerve function, but the first retrochiasmic lesion, the MRI is going to be of more usefulness. In hysterical and malingering, and also in cortical blindness, normal wave and latency almost excludes the diagnosis of hysteria and the cortical hysteria and the malingering. So I'll just show you some examples. This is the first visual evoked potentials. Tracy Berry, you can see that P100 latency is 101 and amplitude is 13. So this is normal waveforms. This another patient who had a Tracy Berry that P100 latency is 100 milliseconds and the amplitude is also normal. So I will report this as a normal. Clinical opinion is normal anterior visual pulsation function, and there is no evidence of optic neuropathy from either eyes. This is another example you can easily interpret. So look at the mid-occipital, and then the P100 latency is 115 milliseconds. 115 milliseconds, the amplitude of the N75 P100 is normal. This is the right eye, and this is the left eye. The P100 latency is 117 milliseconds, and the amplitude is normal. I would report as upper limit of normal range or borderline delay, indicating probably within normal limits, or it could be a mild optic neuropathy. It has to be interpreted in the clinical context. The third example, the latency is locally delayed to 133 milliseconds, well-preserved amplitude indicating a demyelinating optic neuropathy in the right eye. The left eye is also delayed to 135 and the amplitude is normal. So we conclude prolonged latency in both eyes, bilateral, and indicating probably a demyelinated disorders like multiple sclerosis. So to conclude the visual evoked potentials, the pattern reversal visual potentials are most important and sensitive diagnostic tool in diagnosing the optic neuropathies. As I told you earlier, the myelin is damaged, so that's why demyelination is happening. The P100 latency will be delayed with a well-preserved amplitude. Flash evoked responses are limited value, but it does have certain clinical indications like uncooperative patients, sleepy, drowsy, elderly patients, or children where we can use. A good laboratory with a trained technician and an experience of neurologists are of most importance. So we'll move on to the next set of topics, the repetitive nerve test and then single fiber EMG. The neuromuscular junction is very interesting and rewarding. It's an immune mediator. It could be a paraneoplastic, toxic, and congenital. It predominantly affects the ocular muscles, but not the visual acuity. The bulbar and proximal are really involved. You do have two conditions. One is a presynaptic, another one is a postsynaptic. This is a simple schematic representation of the neuromuscular junction, showing acetylcholine, the presynaptic vesicles, where the acetylcholine will be stored in the synaptic vesicle, and when the calcium stimulus comes, the calcium is released, and the acetylcholine released, and the acetylcholine binds to the acetylcholine receptor in the postsynaptic membrane, and then initiate the muscular action. How do you approach a simple patient who had a bilateral ptosis? Clinical examination is important. You just ask them whether they do have a fatigability, diurnal variation, symmetrical or asymmetrical. We do the tensile test. Unfortunately, edrophonium, the tensile is not available in India, so we do the modified news treatment test. Take 1 ml and dilute it with 10 ml of insulin and inject through IV. The ECG monitoring to make sure that they don't have bradycardia. Ice pack test commonly done in the outpatient department itself, and of course the acetylcholine receptor antibody. And coming to the neurophysiology, we do the neurophysiology. We nerve conduction include mimickers of the optic like Guillain-Barré syndrome, Miller-Fisher syndrome, mitochondrial cytopathies, MELAS, Merab syndromes like that. The reparative do have a role, and then we'll talk a little bit more on single fiber EMG in selected cases. It's an electrical correlate of the clinical fatigue syndrome is repetitive nerve system. Thus, the repetitive nerve stimulus exhaust the acid and electrically and then you recorded the all about the basic physiology. We use a low frequency test 1 and 3 hertz so that we can test the neuromuscular junction problem. Weak muscle yields a better result. The proximal muscle the best results. So we do it accessory nerve, nerve, and then the distal nerves like median ulnar nerve, and the facial muscles in the orbicularis oculi and nasalis. Distal muscle also we do it minimi by supplied by the ulnar nerve, beta pollicis brevis by the median nerve. The standard protocol tends to even, and then the positive sign returning towards the baseline 9th and 10th. Look at this. This is a beautiful decremental response. The third and fourth response, fourth and fifth response is slowly down, low amplitude, and then it slightly increase. This is a repair of the decremental characteristic shape or J-shaped phenomena. This is the same patient, and at the proximal again see that clearly a decremental and then slowly towards the 9th and 10th stimulation. So when you saw decremental response, if anything drop in amplitude of more than 10% between the first response to the fifth response is considered as positive decremental response. The decremental response has to be consistent and reproducible in all the nerves tested, proximal nerves, distal muscles, proximal muscles, and also in the cranial nerves. So we do have a standard protocol. Baseline we do it, and then we 10 seconds isometric contraction, 1 minute post-exercise to see if there's any facilitation in the neuromuscular junction, and then minutely intervals up to 3 to 4 minutes.
So can you conclude it's more than 13 minutes?
Okay, just continue. So 3 minutes post. Thus, RN is the baseline is stable, the decrement is reproducible, does it repair after the 10 seconds? So, few slides about the single fiber EMG, the measuring of the variation of the interpotential interval. It does have a special electrode. I've written the review article in Annals of Indian Academy of Neurology. Those who are interested can read. It's the gold electrode, the gold needle. So we use this for the recording of the single muscle action potential from this nerve. Variation in the interval is considered as a jitter. So we measure the variation by using the special needle electrode, and then you could see that no neuromuscular junction variation in this group, and you could see the delayed neuromuscular junction. This is called jitter, and then when there is a weakness, you have failure of neuromuscular transmission. That is called jitter with blocking. This is an abnormal. You can overlap with 100 tracings and then show the delayed or jitter with blocking. So advantages of the single fiber EMG, unfortunately, you need a diagnosis. You can make a diagnosis very quickly. Normal single fiber improves the diagnosis of myasthenia gravis. So to conclude my talk, the myasthenia and myasthenic syndrome remains a clinical diagnosis. Antibody titers are of most of importance. Neurophysiology is supportive, but not in all the cases. Repetitive stimulation is crucial, and set to produce protocol has to be followed, and single fiber EMG in selected cases. Thank you.
Thank you very much, Dr. Arul, for so much of information which we may not have got otherwise. Thank you very much for being with us all through the webinar also. Shall we conclude, Dr. Jyoti?
Yeah, I think that's fine. One quick question, I think, for the panelists regarding the optic disc edema. This is something which I guess postgraduates would be interested to know. How do you actually measure the disc elevation using a direct ophthalmoscope? So this is something which would be asked to them in the practical. So anybody would want, Dr. Mahesh would want to take this question?
Yeah, the more traditional way is to use the direct ophthalmoscope with initially concentrating on the base of the optic disc and then gradually increasing the dioptric power to the apex of the disc. As we go on increasing the dioptric power, we calculate the number of dioptric increase and roughly calculate the elevation of the optic disc. That is one of the more traditional way, but of course the stereoscopic way is newer methods.
That's true, but sometimes questions asked for the postgraduate during practicals is very common. Yeah, I think yes, Dr. We can conclude, no problem. Any panelists, any speakers want to make comments or?
I have one comment.
Yes.
I just had a comment on the initial talk on the monocular double vision. Just for the postgraduates, one point, it is relayed with pinhole. So meaning that it is a disorder of the refractive media. So that one test is extremely important to exclude a monocular double vision.
Yes, yes.
That's a
Thank you
point for
very
the postgraduates.
Yes, yes, very relevant. So I think it has been an amazing webinar with the great speakers who are, and also backed with truly expert panel and very great moderating by Dr. Jyoti, which has helped us get through all the essential things which a postgraduate needs to know in neuro-ophthalmology. Our thanks are due to the administrative staff of AIOS under the guidance of Mr. Kripal, our webinar admin, Mr. Sunil, who takes all the badgering which I keep giving and is so supportive all through the webinars. Sai and Manjula from Numerotech for their support. My own dear ARC colleagues who have been conspicuously absent today. And of course, our dear attendees who infuse so much energy that we are always on the urge to deliver our best on behalf of ARC. Thank you very much. Thank you, one and all. Thank you. Thank you, Dr. Mahesh. Thank you, Jyoti. Thanks, everybody. Thanks a lot.
Thank you.